Bismillah ar-Rahman ar-Rahim. I hope everyone can see the slide presentation. Yes. I would like to thank you, Professor Khalid Talpur and Professor Mohsen Iqbal Saab, for giving me an opportunity to speak on your platform. I'm humbled by the request, and I hope I'm able to deliver the expectations. And I'm also very grateful to Mr. Ijaz Sheikh, who is our president of British Pakistani Ophthalmic Society. He has been very proactive in furthering the causes and the agenda of BPOS to work in tandem with Pakistani organizations to promote knowledge, research, audit, and clinical skills across the board. And I can also see Professor Sadia Farouk. She's also one of the panelists today. Professor Sadia Farouk has been BPOS's Advanced Virtual Glaucoma Fellow for the last 6 months, and we are very proud of her. And now she'll be joining Mr. Imran Masood for hands-on fellowship in Birmingham. And also, I'm looking forward to hear Professor Mohsen, because he's our new fellow starting from February for virtual fellowship. Now, coming back to the presentation, the topic of the presentation is primary angle closure suspect management. Before I actually proceed to the presentation, I would like to share this slide. Now, everyone must have seen this slide in the past in one way or another. So what it shows is that you have 5 levels of evidence of medical practice. Now, this pyramid, at the bottom of the pyramid, or the class 5 or level 1 evidence, is the poorest form of medical evidence that somebody can present on a legal platform. For example, a narrative review or an expert opinion by a senior consultant or an editorial in a journal. So these are the narrative reviews or personal opinions of experienced colleagues. They carry their own weight. However, in a more academic situation, this is a weakest form of clinical evidence. However, when you start studying case reports and case studies, it may offer a bit more robust clinical evidence, but still that is considered as one of the weakest clinical evidences, as there is no design to the clinical study. But when you move on to the case control studies, at that point, suddenly the situation changes and the world starts to listen to you because you have a control arm in your study. However, still, it is not the highest form of clinical evidence. And as you move up the pyramid, you have cohort studies, and the strongest form of the clinical evidence is randomized controlled trials. Now, once you will realize that on a single topic, there may be multiple randomized controlled trials, and each trial may have a different outcome. Some trial may suggest that lowering pressure is helpful. Some trials may suggest that lowering pressure to that extent is not really helpful. So more the trials, more information would be handed over to you, and at many times that can be conflicting in nature. So to resolve that conflict, and the experienced doctors or the experts and leaders in that subspecialty, they get together and they review all the published evidences, which include from category 1 to category 3, and they may lay down their systematic review. Now, this systematic review of various evidences then forms the guidelines of any society. For example, if you have Pakistan Glaucoma Society or Pakistan Glaucoma Association. Now, they will offer guidelines to Pakistani surgeons and doctors after going through the systematic reviews which suit the Pakistani general population. So this systematic review becomes even more important than randomized controlled trial. And above that is the meta-analysis. Meta-analysis cannot be done unless you have similar kind of studies. So if you have 4 or 5 different RCTs, then perhaps you can also do the meta-analysis. So the meta-analysis and systematic reviews are the most robust kind of clinical evidence. So today in my presentation, when I will be discussing something, it will be purely on the basis of clinical evidence of various levels, very likely to be RCT level. So to present the same pyramid of clinical evidences in a more layman language, this is a slide which shows that the weakest form of clinical evidence and like narrative review or a personal opinion may be very primitive in the human evolution as compared to the RCT, which is presented as a modern human being. But a modern human being who's a scientist and a researcher, he is being presented by a systematic review or meta-analysis. So this is how we'll move forward. We'll be discussing evidences, and we'll be discussing robust evidences to support what I'll mention today. So the first, when we talk about the narrow angles, we talk about the occludable angle. And the first thing first, that what is an occludable angle? So if you search the literature, it is littered with many different definitions. And you will come to a realization that there is no clearly defined threshold that what extent of narrow angle is defined as occludable angle. Occludable angle is an angle when you say, okay, angle is now clinically narrow, significantly narrow, with a significant risk of acute angle closure. So if you look at the epidemiological research standards from Alaskan, South African, Mongolian, Singapore, Bangladesh, and Chinese populations, you will realize that these research standards are defined by at least 3/4 of the angle to be blocked to be called as clinically significant iridotrabecular contact or occludable angle. I will refer iridotrabecular contact to ITC in my future presentation. But if you look at what Thomas suggested that ITC or iridotrabecular contact of 180 degree or approximately 2 quadrants may be classified as an occludable angle. But initially, before the concept started, Becker and Schaff originally suggested that maybe even only 20% of iris touching the trabecular meshwork, ITC, may be defined as an occludable angle. So the more you review the literature, more standards you come across, ranging from 20 degrees to 270 degrees, or 3 quadrants of the angle to be defined as occludable angle. Now, why? The question arises why there is such a discrepancy and why there is no clearly defined threshold. Now, World Glaucoma Association went through all those evidences and they presented their systematic review, and they said that 2 quadrants or 180 degree of ITC may be defined as occludable angle. Now, the reason why there is such a huge difference between the thresholds is that whenever there is ITC, whenever the iris touches the trabecular meshwork intermittently or continuously, either in an appositional form or as a peripheral anterior synecdoche or PAS, there are likely to be histological changes of the trabecular meshwork. at that spot. So I repeat myself, it is likely to have histological changes at that spot. Not necessarily, but likely. But even more important is that the ITC not only causes histological changes at the site of iris and trabecular meshwork touch, but it may be happening away from the touch. So for example, if ITC is happening at 12 o'clock, you may still have histological changes going on at around 6 o'clock angle where there is no ITC. So this is a photograph of a very healthy normal trabecular meshwork, and you are actually looking at the uveal meshwork, uveal component, and you will see that the beams are quite nice and healthy, robust looking beams with quite a bit of inter beam spaces for the aqueous to percolate through. And if you look very closely, that these beams seem to be covered by a very shiny, healthy endothelium. And occasionally you may find cells like these, which are just pigmentary cells. And they, so when you look at when you do gonioscopy, you see occasional pigment dispersion, pigment in the posterior trabecular meshwork. But see what happens when you are dealing with a chronic angle closure glaucoma. Now, in chronic angle closure, there is either an appositional ITC of 2 quadrants or more, or there may be a peripheral anterior synecdoche or synechial ITC. So you classify ITC into either appositional or synechial. So whatever the reason, you may start finding that not only at the site of the ITC, but also away from the site of the ITC, the trabecular beams have fused. So rather than cylindrical position like that, you can see they are now fused. And there are very few spaces for the aqueous to percolate through. And it's not only fused, but you will also see these knotted appearances of the beams. Actually, they're not really the trabecular beams, but that's actually the deposition of the extracellular matrix and amorphous material, which is not cleared by the endothelium. So over here in healthy trabecular meshwork, the beams have endothelium, and these cells are responsible to secrete macrophages, or track macrophages, etc., and modulate the extracellular matrix of trabecular meshwork. And as that endothelium is lost, so you can see this beam is now covered by a very dusky amorphous material. So the trabecular cells, they start losing their function, their normal physiological function, and there are lesser spaces. So it's not only mechanical, it's also on a biological level that the water or the aqueous doesn't percolate through, so the pressure starts to rise. But see what happens in an acute attack of an angle closure. You can see the whole architecture of the trabecular meshwork has been destroyed. You can't really see the beams. You can see some beams here, but over here the architecture has been destroyed, and you can see large macrophages and big pigment clumps, which are now accumulating in the trabecular meshwork, and they're not being cleared. So I won't discuss this one. So this now begs a question that why World Glaucoma Association, after their systematic review, came to a conclusion that 2 quadrants or 180-degree of ITC may be classified as significant. So a very simple way, but not by no means this is the end answer. This is rather a very, very simple explanation and a very rudimentary explanation, which can be explained simply by a Goldman equation. So I would like to borrow your mathematical minds in the Goldman equation. The Goldman equation says that the perfusion pressure is directly proportional to the resistance of aqueous flow. Now, what is perfusion pressure? Perfusion pressure is the drive force which pushes the aqueous out of the trabecular meshwork, i.e., it is a difference of intraocular pressure and the episcleral venous pressure. So this red arrow that you see here, this force is actually the perfusion pressure, which is the difference between the intraocular pressure and the episcleral venous pressure. So as we all know, the normal episcleral venous pressure is 9 and average physiological intraocular pressure is 16. So if I put the perfusion pressure as the difference of IOP and the episcleral venous pressure, then 16 minus 9 turns out to be 7. I can also write it more simply like this, that episcleral venous pressure of 16 is equal to perfusion pressure of 7 and episcleral venous pressure of 9. And just by making it more simplified as we are taught in our schools. Now, coming to the point that if, for example, the resistance is increased, for example, if ITC happens, if the resistance is doubled, i.e. if half of the angle is blocked, then we can safely assume that the resistance has doubled. So if resistance has doubled, then according to Goldman's equation, the perfusion pressure should also double. So that means this figure of 7 will become 14. The perfusion pressure will become 14. If the perfusion pressure becomes 14, adding episcleral venous pressure of 9 means that the intraocular pressure will go to around 23. So you can see that despite losing 50% of the trabecular meshwork, your intraocular pressure now rises to 23. And 24 is the usual cutoff point of physiological range. Hence, this is why 2 quadrants have been suggested as the minimum as the occludable angle, the threshold for the occludable angle by the World Glaucoma Association. Now, coming to the broad classification of narrow angles can be classified as either suspect, disease, or narrow angle glaucoma. The narrow angle suspect is when you have occludable angles. That means when you have ITC of about 2 quadrants, but then you have no other sign. You do not have high pressures, you do not have peripheral anterior synechies, you do not have symptoms, you do not have any optic nerve damage. So such a patient is called narrow angle suspect. And if the IOP starts to go high, or if patients start to develop peripheral anterior synechies, or if they start to develop symptoms, intermittent symptoms with headaches in trigeminal distribution, or eye ache, or intermittent halos, blurry visions, then you call them as narrow angle disease. But if this disease causes optic nerve damage, then we call it glaucoma. So this is how we will deal with the presentation in coming minutes. Now, having discussed the basic concepts around the classification and the ITC and the occludable angle, now we move to the load or the prevalence of narrow angle. And so this was a paper which presented that by 2020, you will see over here that the primary open angle glaucoma in worldwide would be around 60 million load, approximately, whereas angle closure glaucoma would be only 20 million. So that is 1/3 of the open angle. But if you look at the load of blindness caused by the blood glaucoma, then you will see that in 2020, whether it's open angle or close angle, they almost share a similar load of blindness. So narrow angle is very, very important, and the load, economical load, financial load, the medical clinical load that you see in glaucoma clinics leading to blindness is very similar between open angle and angle closure. So this was a systematic review, again, a very strong clinical evidence, and it showed that in European white populations, you can see the prevalence of narrow angle or angle closure glaucoma is around 0.4% and 40% in patients over the age of 40, but it almost doubles to 0.95% over the age of 70, and females are more likely to be more affected. But look at this figure, 1 million people across Europe have angle closure glaucoma. Now, these are the patients who actually have the optic nerve damage done by angle closure glaucoma. So the workload is huge. Now, this is very quick real-life data from my own private clinic, ranging over 3 years. And you can see in 3 years, about 14,500 patients were referred to me, and about 10,500 out of them, 10,500 they attended. And out of these 10,500, I saw about 656 narrow angle pathology, which amounts to be around 6.25% of the total referral, which is fairly high. Now, if you look at the data or the RCTs presented from Moorfield and from Scotland, they will say that the workload of angle closure in the clinic ranges from 18% to 24%, which in other words means that if you are seeing a clinic and it has 10, you have 10 people referred to you for glaucoma, you are likely to see around 1 to 2 patients of angle closure out of 10. So this means that if in your practice, especially in Pakistan, which has a higher risk of angle closure than European population, if you're not seeing 1 to 2 patients of angle closure every 10 patients, then perhaps you need to concentrate on your gonioscopy skills a bit more. And even in my study, you can see the narrow angle disease and glaucoma make up of about 0.34%, which is very similar to this. So moving forward, this is a very, very interesting graph, and it shows that the people who are senior enough to see that with time, the trend of presentation of acute angle closure glaucoma in our emergency clinics is reducing. So previously, about 20, 30 years ago, every other day you will find a person with angle closure glaucoma. Now it's far less common. The load is not that much. Why is that happening? So if you look at this graph, you will see that by the time the presentation of acute angle glaucoma is dropping, at the same time, the phacoemulsification rate is high. This is the time in 1995-96. At this time, there was a sudden shift from extracapsular surgery to phaco, and that led to huge number of cataracts to be done. And so people can say, okay, as the cataract surgery is going up, hence the angle opens up, and hence there is lesser presentation of acute presentation of angle closure. But at the same time, about 1996, 1998, and 2010, at the same time, you will see that the rate of YAG peripheral iridotomy was also rising exponentially, because at that time, YAG machines became available, more widely available at cheaper rates. And people started to shift from surgical peripheral iridotomy to laser peripheral iridotomy. So you can also argue that rather than cataract surgery, it was higher rate of YAG PI, which led to the lower presentation of acute angle closure. So to solve this mystery, whether this is the YAG PI which reduced the rate of acute presentation, or is it the cataract surgery which reduced the rate of angle closure, a very nice study from Scotland came up in 2012, and that showed that as the cataract rate rises, the presentation of the acute, the solid line, is reducing. And it also shows that it has nothing, this reduced rate of angle closure has nothing to do with the rate of increasing YAG PI. So you can see this dotted line in YAG PI. So there is no relationship between them. Rather, only at the far right corner, you can see the YAG PI rising up, but it has no real relationship with the reduced rate of angle closure glaucoma. It could be associated with cataract surgery. So this was the obvious data analysis suggesting that perhaps cataract surgery is a more important aspect in controlling the acute presentation. So to solve this dilemma, whether YAG PI is more important or whether cataract surgery is more important, 2 trials were simultaneously, not simultaneously, but one after another, they were set up. One was called Zap Trial, and other is called Eagle Trial. And Zap Trial only deals with the angle closure suspect, where there is occludable angle, but no evidence of raised IOP or glaucoma, whereas Eagle Trial deals with angle closure disease and angle closure glaucoma. And the key questions for both of these trials was that, is there any benefit of using peripheral iridotomy to prevent primary angle closure disease or glaucoma? And the second question was, is phacoemulsification safe and effective treatment of primary angle closure disease or glaucoma? So both of them, they were randomized controlled trials. And Eagle trial stands for effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. So the stress is on early lens extraction. That means there's no cataract. And the Zap trial stands for Zhongshan Angle Closure Prevention Trial. That's the Chinese province where the study was done. So before I move further, I will now share 6 clinical cases. 6 clinical cases. And all of these clinical cases, they are the cases of primary angle closure suspect. That means all of them, they have more than 2 quadrants of ITC, at positional ITC. All of them, they have pressures of less than 18. All of them have healthy discs, full fields, and no evidence of disease or glaucoma. So first, this one. So this is the high frequency ultrasound, or UBM. And in this case, you can see the angle is closed, but the ciliary body is rotated forward. The iris is of this shape. Second case, you can see the ciliary body is rotated forward, but there is a ciliary sulcus present, and there is the iris root is inserted into a plateau-like fashion. And on this side, there is no definite ITC. There's little ITC, but if you look at the rest of the ITC was more than 180 degree. On this side, let me move this. Okay. So, and on this end, you can see there's a large iris cyst leading to the Plateau Iris formation. On this one, you can see a ciliary body cyst leading to anterior ciliary rotation and ITC in a Plateau Iris. On this one, you can see there is a very large lens leading to forward movement of lens iris diaphragm and narrow angles. And in this one, you can see a very thick, juicy iris with normal ciliary body and angle closure. So you can see angle closure can present in so many different, these are just 6 cases I picked up randomly. But if you see 10 cases of narrow angle and do high frequency ultrasound, you'll see there will be 10 different clinical scenarios. So what do you do in these 6 cases? Will you just wait and only do cataract surgery when the vision starts to get affected, or would you like to do YAG peripheral iridotomy in these cases, or just a watchful wait? So you are presented with dilemmas. A patient is 6'5", pressure is 18. He is just 45, 50 years old with significant angle closure, but no symptoms. If you do cataract surgery and you end up in trouble, there is very little justification to the patient and to your colleagues and even to the law what to do. Why did you do the clear lens extraction? So so how would you deal these 6 cases? We will come to these. Usually I take a show of hand at these places, that how many of you will wait or do YAG PI or cataract surgery, but in a virtual situation it may be difficult. So I'll come to these in detail in a minute, but let me first briefly go through the Eagle trial. Now, Eagle trial, which is the effectiveness of early lens extraction, was done over 5 countries and 30 different hospitals. Most of them, they were in the United Kingdom. And the eligible patients were all over the 50 years of age. They did not have cataracts, and they were newly diagnosed with primary angle closure with ITC and pressures of over 30 milligrams. But the group also included patients with pressures of only 21 if they had optic nerve damage. So if there was an evidence of optic nerve damage, that pressure of 21. If they had no optic nerve head damage, it was just a disease, then pressure of 30. So then these patients were randomized to clear lens extraction, or they received standard care with laser peripheral iridotomy followed by the treatment. So the Eagle trial was unique in a sense that this was one of the initial trials where they also included quality of life. The quality of life in this case was done by the EQ5D performer. I'm not going to go into details of the quality of life and the critical analysis at this point, but I'll just mention that you can see that at 36 months, the patients who had laser peripheral iridotomy, their quality of life was lower as compared to the patients who had cataract surgery done. So patients who had cataract surgery done, their quality of life was very similar to the baseline as they had before the cataract surgery. But patients who had YAG-PI, their quality of life was significantly reduced. And it can be due to many different reasons. So that you can have glare, and you can have halos, you can have light sensitivities, and sometimes even double vision. So all of these things can really affect the quality of life of patient in certain lighting conditions. Now, they also looked at the medicine load, and they found that in the lens extraction group, the number of eye drops was a lot less, significantly less, as compared to the group who had YAG-PI done. So far, patients who had cataract surgery done, they had lesser medicines and they had a better quality of life. And then the third most effective thing was they also found that it was more cost effective to do the cataract surgery than to do YAG peripheral iridotomy. Now, this cost effectiveness is a very technical term, is a health economic term, and it deals with the quality adjusted life years. In all first world countries, whether you're dealing with any European country, UK, China, Japan, Australia, or Canada, America, in all of those countries, there is a special segment of health economists who are continuously working to find whether a treatment is worth doing or not. So in the UK, they found that if you do cataract surgery, it's actually more economical than doing YAG-PI. And the reason is because a person, because the economical means that a person is able to contribute more to the society more effectively. For example, if a patient had cataract surgery done, if he is spending less money on his eye drops as compared to the laser PI group, that means he has more savings. If he has more savings, that means he is able to contribute towards more the taxing, towards spending, and towards the overall economy of the country, as compared to a person who's on YAG-PI and spending more money on his eye drops, or his quality of life is not very good and he's not as effective contributor to the society as compared to a cataract surgery patient. So at this point, I'll share a 3-minute video just to give you what is quality adjusted life years and what is the health economy.
Hi, my name is Dr. Sanjay Sharma. I'm a professor of ophthalmology and epidemiology at Queen's University. As a researcher, I am very interested in a particular area of epidemiology called health economics. Part of the goal of health economics is to work out the cost-benefit numbers for new interventions in a way that can help doctors and policymakers make the often difficult decision on which interventions to pay for and which may be too expensive for the public healthcare system to fund. I want to give you a high-level overview on how we do this. The key thing is being able to put a value on a new drug or procedure. In healthcare, we measure value as a unit called QALYs, or quality adjusted life years. One QALY is equal to living for 1 year in perfect health. So how do we work this out? Well, what we do is we look at the average person with a specific disease, and then we look at all the outcomes of that disease, both with and without the intervention that we are evaluating. For each possible outcome, we assign a probability and a utility score. The utility score is a measure of how much your quality of life would decrease with a certain outcome. For example, someone with wet macular degeneration might say that if they went blind, their quality of life would decrease by 55%. This would mean a utility score of 0.45. Using a mathematical model called a Markov model, we combine the utility scores and probabilities and other factors to determine the average benefit to someone with the disease who takes the drug which we are evaluating. We calculate that benefit over the course of the treatment and end up with the increase in qualities caused by the drug. The next thing we do is look at the cost to society as a result of each outcome. Most obviously, we have to look at the cost of paying for the drug treatments, but then we also have to take into account the total cost of each possible outcome associated with both receiving the treatment and not receiving the treatment. For example, in eye care, we also have to consider the cost of the healthcare system if a patient went blind, including personal assistance, patient education, and continuing medical care. In this case, the blindness could have been caused by an adverse effect from the drug or through not taking the drug at all. Once we have determined the cost, we can then calculate the cost per QALY, or how much does it cost us to gain the equivalent of a year in perfect health for a patient. This cost per QALY becomes a standardized metric to evaluate new interventions. The typical scenario is that a new intervention provides an improvement in either the length or quality of life, but costs money. And health economists and doctors argue it out as to whether the government should pay for the intervention. Most governments fund things that cost less than $50,000 per QALY and do not pay for others that are more costly. It is a complex analysis, and we've only brushed on the surface, but I hope that we've been able to give you a small glimpse into how health economists work and how their analyses help us to run our healthcare system with a reasoned approach.
Now, thank you very much for bearing with this 3-minute video, but the message honed is that the cataract surgery has a QALY of 14,084, and in the UK, if anything is less than 20k QALY cost, then it is funded by the government. The NHS system of the government was initially branded when it was brought to the UK, free healthcare. It was said to be Umar Health System from Hazrat Umar Farooq. And so this was an Islamic concept that the healthcare is provided free in the society. Now, in Pakistan, you have free healthcare and you also have private healthcare. It does not mean that a patient who is coming to you in your private clinic for him the QALYs do not apply. If he is coming to you and paying from his own pocket, that means his resources are being depleted. So you must always ethically offer the correct treatment, because if you offer him the wrong treatment, that will affect on his resources, that will reflect on his ability to take care of his children, that will reflect on his ability to contribute to the society in an effective and more useful manner. So cost effectiveness and health economy is very important. So what Eagle trial mentioned, that not only the quality of life is better in cataract surgery patients as compared to the ACPI group, in not only the medicine load is lower, but also it is more cost effective. Is it really cost effective in Pakistan? It's a task that Professor Khalid Talpur might actually work on. And we have also trained our BPOS fellows perhaps they can also take up this this task in the future. But the 3 point is that you have cost, you have quality of life, and you have less medicine, all in favor of cataract surgery. So, the outcome is that clear lens extraction showed greater efficacy and was more cost-effective than laser peripheral iodotomy, and should be considered as the first line of treatment. Now, that brings us to the Zap trial. Now, the Zap trial was done in China, and Paul Foster was also the part of the Eagle trial. He was also a part of this, and Ming was, I think, Paul Foster's fellow. So in that trial, this is a very, very beautifully designed trial. They enrolled quite a number of patients, over 890 patients, and then at the end of the study, they were left with about 780 patients or so. So what they did, they randomized patients, one eye of the patient to YAG PI, and the other eye was left as a control eye, and they did nothing to it. So this was beautifully designed, because in this case, the controls are, the age is controlled, the sex is controlled, the refractive error is controlled, because they're likely to be very similar between two eyes. And the axial length is controlled, the shape of the ciliary body, the morphology of the angle is controlled. So, so like this, a very good controlled benefit of YAG PI could be sought out. So the design was initially meant, the trial was initially meant to run for 3 years. So after 3 years, the results came, and believe what really happened. There was no protective effect, zero, no protective effect of YAG PI in narrow angle group in the eyes which received YAG PI as compared to the control. So at this point, the steering group of the Zap trial research group, they sat down and they decided that the trial may be extended for another 3 years. Now, this is not an easy decision, because already millions have been spent, and few more millions will now be spent, and possibly there may be no useful outcome at all. But anyway, it was approved, and after 6 years, they found that there is actually a significant benefit of doing YAG PI, though small, but significant benefit. So after 72 months or 6 years, they found that only 5 of the control eyes had an acute angle closure attack, as compared to only 1 eye in the LPI group. So looking that into more detail, they found that 3 control and 1 YAG PI eye had acute angle closure after dilatation. So they put the statistical test again and found that whether the attack happened with or without eye drops, in both cases, the difference is not statistically important. So the second landmark or the end point of the study was to check the pressures on 2 consecutive visits, whether it is high or low. So they found that in about 5 of the control eyes, after 6 years of monitoring, only 5 eyes had 2 pressure spikes in 2 consecutive visits, as compared to only 3 YAG PI. Not, again, that important. But what actually made the difference was the peripheral anterior sinus keys on gonioscopy. So if, and for more than 1 clock hours. So they found that control eyes were twice as likely to have peripheral anterior sinus keys as compared to the YAG PI group. So then they tried to find the risk benefit, and risk versus benefit, and they found that the number needed to treat to cause a benefit to a single patient is very, very high. So you have to treat about 263 patients in a year to find a benefit to a single patient. So this meant, though there is statistically significant benefit by doing YAG PI over 6 years, but but very, very few patients benefit with it. So the logical explanation is then PI should only be offered to those people with very highest risk of primary angle closure glaucoma. Now, these are the patients who are likely to be lost to follow-ups. They are the patients who are likely to be on drugs which can cause anterior rotation of ciliary body, like benzodiazepines, tricyclic antidepressants, etc. Or these are the patients who are showing spikes or showing symptoms of headache in trigeminal area. So these are the patients where you may consider the YAG-PI. So again, the outcome of the two trials is that the clear lens extraction for angle closure is the preferred initial intervention, and YAG-PI may be only offered to the highest risk patients because the number needed to treat is very high. And this is another study, another randomized controlled trial, trial, and it again found that the number needed to treat, though lesser than that of the Zap trial, but still it's a fairly high number to treat to find benefit to a single patient. Now, I showed this slide to show that angle is a very, very complex structure. It's a very dynamic structure. There are 1,001 different parameters to be studied. However, these parameters, if you read the literature, it's littered with a number of studies talking about different parameters and their association to angle closure or chronic angle closure attacks. But none of them, they have high sensitivity and specificity together. If they have high specificity for, if a test has a high specificity, then they will have a low sensitivity. So you can, for academic reasons, look at those parameters like angle opening distance at 500, 750, 1,000 microns from scleral spur, but these are more academic. Clinically, in a busy clinic, they offer little benefit. However, what does offer a benefit is that ultrasound or ASOCT, ultrasound is better than ASOCT, and it can offer you a very, very important clue that what is the extent of the ITC. ITC, like in this one, you can see there is no iridotrabecular contact. This scleral spur is identified by this protuberance. And over here, you can see there is no ITC. Iris is not touching this scleral spur. Over here, you can see the protuberances being blocked by the ITC, but the extent is very shallow. And over here, you can see the extent is quite high. So a lot of area is being blocked. And over here, you can see that although a lot of area has been blocked, but deep down, there is a small space which is still open. So if water tends to flow through here, it can actually come in the space and maybe picked up by the trabecular meshwork. So again, this is another photograph that this is a Plateau Iris. Am I running late, sir? Okay. So this is another presentation where you can see anterior rotation of ciliary body, which is leading, which is tenting the iris. And you can see Plateau Iris, but you can see the angle is open. But as soon as the light is taken away, you can see the angle closes up. So it's very important that you do colonoscopy in an isolate condition. So this is another case, which is a relative pupillary block. So you can see the is everything okay, Mohsin sir? So you can see the anterior convexity of the iris, showing the relative pupillary block, showing that the pressure in this area is more than this. And this high pressure is leading to the angle closure. And after you done the YAG-PI, you can see that the interior convexity is lost and the angle tends to open up a bit. So now this brings us back to our same 6 scenarios. Now having understood the current clinical evidence presented by the Eagle and the Zap trial, you would now like to either wait or do clear lens extraction rather than doing YAG-PI. But let's see. So in the first case, you have a large ciliary body which has rotated forward, and if you look at the profile of the anterior iris, it's in a plateau iris shape, and there's a very high ITC. If you look at the posterior profile of the iris, it's quite flat, indicating that there is no relative pupillary block. If there is no relative pupillary block, then YAG-PI is a useless procedure. So if you do YAG-PI in this group, it's an unwanted, unnecessary procedure which will do no benefit at all. So what would you do in this case? This is ITC is more than 2 quadrants, pressure is normal, vision is 6x, the patient is quite young, and would you do clear lens extraction or just wait? So if the pressure starts to go over 30, then you have a strength of a randomized control trial or Eagle trial behind you to offer clear lens extraction, if you are an experienced cataract surgeon. If you're not an experienced cataract surgeon, then you need to refer the patient for clear lens extraction to an experienced surgeon. And nobody would point finger at you that why did you offer clear lens extraction in a young patient with 6'5" vision. In this patient, you can see the root of the iris is actually the smaller than the limbal. If you look at the limbus width and then look at the width of the root iris is actually slimmer than the limbus, and there's less ITC, although the ciliary body is rotated forward, but you have a ciliary sulcus there. So in this plateau iris configuration, plateau iris syndrome, unless the pressure starts to rise, I would not do anything. Again, you don't see an anterior convexity of the iris. There is no relative pupillary block. And doing a YAG-PI is a useless phenomena here. You can still watch, or if the patient is a high-risk group, like you're planning to start the patient on antidepressants or anti-allergics, etc., then you may consider cataract surgery. Again, this is a clinical decision between you, patient, and your personal circumstances in a certain economic and social background. Again, in this one, you can see the iris steeply rises up in a plateau form and then flattens, a typical plateau iris, but ciliary body is way back. You can actually see the ligaments being stretched. And the iris is in that shape because of a large posterior iris cyst. Now, iris cysts is entirely different phenomena. And by doing a YAG-PI, you may not perforate one cyst, as they may be confluent, they may be multiple, and also you may or may not do any benefit to this patient. So again, in this case, you would like to see whether you would like to do a cataract surgery or just sit and wait. You doing YAG-PI may not be very helpful, rather it may be a counterintuitive if you induce too much of inflammation. So this one is a ciliary body cyst causing anterior rotation. Again, you can see slight anterior convexity, so there may be a little bit element of relative pupillary block, so it may be a mixed mechanism. But if you do not find any high risk in this patient, you can still sit on the patient, wait, monitor the patient regularly, and when the vision starts to get worse, maybe you can offer cataract surgery rather than doing YAG-PI. However, in this patient on the presentation, you can see from this scleral spur to this scleral spur, there's a reference plane, and then the distance from the middle of the lens to this reference plane is called the anterior vault height. And if you look at this anterior vault height, it's around 1,000 microns. The usual physiological value is around 350, 450 microns. So this is about 3 times more, indicating that the cataract is actually, or the element of narrow angle is phacomorphic, is the cataract leading to it. And you can see the iris is quite thin over here. So there are physical signs of actual lens pressing and plastering and thinning out the iris. And you can see the ciliary body is hardly visible. It's quite small. So there are physical effects. So despite no spike in pressure, you can see that the eye is already under significant stress. And this is a high-risk group. Even if pressure is not high, leaving this patient alone is high risk. So you would like to do cataract surgery here. Again, if you do YAG-PI, you're not going to do anything. Some people like to do YAG-PI first and then do cataract surgery. That's a futile exercise. You're just promoting more inflammation in the eye and not achieving anything. This is an Asian patient. You can see such a thick, juicy iris, and you'll really struggle to do YAG-PI in this case anyway. And even if you manage, the relative pupillary block is so little that you may not find any useful benefit. So it is very important that you look at each case of narrow angle properly and then decide whether you're going to do watchful waiting or do YAG-PI or do cataract surgery. And if you choose to do cataract surgery, there is enough evidence by RCT to support you, even if you do 6665 vision cataract surgery. Thank you very much. I'm happy to take a few questions before we go on to the second presentation. Thank you for bearing with me. It was a long 45-minute presentation. Hello?
Yes. No, you have to come here. One question, sir.
Yes, sir.
Thank you, Rashid. It's Khalid here again. So thank you very much. Wonderful, excellent, talk. I just want you describe all the risk factors, the angle and everything. What about the axial length? Has it got any role?
A lot, sir. The axial length, as you know,
Yes.
Can you hear me? Yes, sir. Axial length is very, very important. That's why when they did the Zap trial, they actually noted down the axial length of all those patients. They did biometry of each patient. And with time, you'll see more publications coming out dealing with the axial length and the risk of angle closure. But as you know, the axial length can further be divided into the anterior segment dimensions and as well as the posterior chamber dimensions. Now, if the axial length is less than 22, of course, you are moving into a shorter eye with more crowded things. But more importantly, as the axial length drops, then especially if the white to white height, as the axial length gets smaller and smaller, you go into the realm of microphthalmia. The microphthalmia could be relative anterior microphthalmia, where even if the axial length is okay, but the anterior chamber and white to white dimensions are quite smaller. So in those cases, you can see that not only there is a physical crowding of the structures, but at the same time, you may be exposed to other systemic and local ophthalmic diseases associated with microphthalmia, thus making things quite complex. So this is why whenever you see small axial length, especially bordering onto the microphthalmia, it is very important that you deal these cases. These cases should be dealt by a senior consultant only. You can get away with the cataract surgery done by an experienced registrar and you may have never experienced any problem, but this is not the right routine. So these things should be dealt by a senior consultant who understands how to deal with the cataract surgery and microphthalmia or in the shorter axial lengths, because they may be having uveoscleral effusion. They are more predisposed to aqueous misdirection, malignant glaucoma during cataract surgery, during the cataract surgery, as well as after the cataract surgery. And if it's not planned well, and even one patient in 10 years ends up in a problem like that, that I would believe is clinical negligence. So yes, axial lengths play a very, very important role. It has direct relationship to the management, and as the axial length gets smaller and smaller, I'll be more careful to offer cataract surgery. Still, I will do the UBM to see that what kind of narrow angle it is there. Usually, it's the phacomorphic element. and leading to crowding of the angle. But this cataract surgery in smaller eyes should be dealt with. Anything less than anything approaching 20 millimeters, I'll be very, very careful. I would not let any experienced surgeon do it unless that surgeon is aware of the complications which may arise with microphthalmia during the cataract surgery. Such cases should be done under general anesthesia with low carbon dioxide tidal volume, and your expertise should be there should you want to make scleral windows, etc., to prevent choroidal hemorrhages. So that's an entirely different ballgame. I'll be happy to discuss that in more detail some other time, but we can leave it. I hope I answered your question.
Thank you so much, sir. We can proceed to the next presentation. But one more question. How would you compare UBM with anterior segment OCT, as it is more available here and we can do these cases? So do you prefer it, or UBM has more role to see the angle and ciliary body? Thank you.
Thank you, Mohsen. An excellent question, I would say. I like UBM more because it allows me to see the angle in a more dynamic situation, and it allows me to see the ciliary body and as well as a supraciliary space in more depth. In ASOCT, you will find that the ciliary body size, dimensions, and morphology is excluded, and the deepest part of the angles are actually electronically generated rather than a true picture. So I actually like UBM more than ASOCT, but ASOCT is more freely available, and more importantly, ASOCT can also give you interior lens vault height far quicker than UBM. So it has its own benefits. I would suggest you to do it in busy clinics. At least something is still done. But looking at the parameters of ASOCT, like opening distance and TSI areas, etc., those are more academic. I would not pay much heed or that the AOD 500 or 750 is very small for this patient, is at high risk. Those are more academic things, and I would not suggest to pay unnecessary heed to such parameters. I would rather just use ASOCT to calculate interior lens vault height to assess the phacoomorphic element, or may like to see the curvature of the iris to see if there is any relative pupillary block. Or it may be very easy to identify a plateau iris configuration if you're not very good at gonioscopy. But neither UBM nor ASOCT is a replacement of gonioscopy. Gonioscopy is a must essential skill for every glaucoma patient.
Thank you, sir, for the detailed answer. Please continue with the next presentation.
Okay, so okay, so the next screen is now this is this presentation is very interesting. I was still preparing this presentation till last night, because once I prepared it, I lost all of it. So I had to start from the very beginning. And that's why you won't see any fancy slides in this. But anyhow, I'm very, very grateful to each one of my colleagues in Pakistan who took time to fill the trabeculectomy survey by BPOS, and not only filled themselves, but they also promoted and encouraged their colleagues throughout Pakistan to fill this survey. And the information that we receive is so useful. And I hope, and I sincerely hope and pray to God that this survey will be a landmark survey and can start to change the practices of trabeculectomy in Pakistan. So the objective of the survey was to assess the national practices and to compare whether these practices are in unison to the international standards and practices. And while doing that, we may also like to find the strengths of local practices and as well as weaknesses and need for further training in the local practices while performing trabeculectomy. And then, of course, to recommend the changes needed to perform a safe and, more importantly, a predictable trabeculectomy. Now, trabeculectomy is the gold standard procedure for glaucoma. No MIGS, nothing else on this planet Earth is as effective as trabeculectomy. And if trabeculectomy is performed in a predictable manner, then this might be one of the safest procedures in your hands. If you look at the literature, you'll always find that the complications related to trabeculectomy are significant, but that is mostly due to the poor technique. The modern trabeculectomy, though is not an entirely safe procedure, but the complication rate is very low and success rate is very high. If you look at the national ophthalmology data, the complete and the success rate, the qualitative and complete success rate combined together is around 97%. And in simple, uncomplicated cases across the world, in many centers, the success rate is even 100%. So trabeculectomy stays the gold standard, and no matter how many MIGs are being introduced in next coming years, none of them is likely to replace trabeculectomy. It's highly unlikely that in our lifetimes we will see a procedure which will replace TRAB. So it's very important. Now, TRAB, so the aim of trabeculectomy is I'm not talking about the clinical outcome, I'm talking about surgical outcome. The aim of the trabeculectomy is to create a diffuse bleb like this, a diffuse posterior bleb, which is slightly elevated and has normal vascularization. Very, very important aspect of the bleb is the vascularization. And more importantly, it leads to a predictable and controllable outcome in terms of intraocular pressures. So the first question of the survey was, so when we sent the survey, we got very healthy reply. I actually got 142 replies, but when I was doing snapshots, which I saved earlier, at that time, I only had 138 reply. I have to remove one reply because it came from Baltimore. It wasn't a part of Pakistan. So we had quite a high number of responses from about 35 cities. The options of cities that were given to over here from Bahawalpur to Wakand, they were arranged in alphabetical order, but they were taken from the population consensus of Pakistan. And these were the 24 most populated cities. They were representing 24 most populated cities of Pakistan. The last option was other cities, and which allowed people from less populated cities and villages and smaller areas to contribute to the survey too. So you can see here, the biggest contributor was from Peshawar. It seems that Peshawar does the most amount of trabeculectomy, closely followed by Lahore. And then Rawalpindi and Islamabad combined together, they were the twin cities, they were performing perhaps more TRABs than Karachi. Though we had a healthy reply from Karachi, but I was expecting it to be far more than Lahore, but unfortunately we didn't get enough data. After that, you can see we got significant data from almost all the other top populated cities of Pakistan. In the other segment, you can see the other segment is also a big proportion of replies, and it includes Mirpur Azad, Jhelum, Mansehra, D.I. Khan, especially, and Aptabad, Bahawal, Nagar, Bihari. So we had a huge and a very general representation of Pakistan. However, not much from Azad Kashmir. So this, I presume, means that we are actually looking at this is a fair representation of how people perform trabeculectomy in Pakistan. So the next question was, do you actually regularly perform trab? Now, this is an important question, and I will let you know why this is an important question. So, and we found that about 58% of people, of the surgeons, they actually do regular trab. Regular trab was defined as a surgeon who does at least 1 to 2 trabs in a month. So if you're doing at least 1 or 2 trabs every month, you are a regular trab surgeon. And 60% or 58% of our surgeons did regular trab. About 42% of surgeons did not do 1 or 2 trabs per month. Maybe they did 4 or 5 a year. So following that, we asked that please state the number of years since you've been performing trabeculectomy, and you will see that the highest portion, the maximum number of trabs, is done by the surgeons who have at least more than 10 years of experience after their post-graduation, like FCPS or FRCS, etc. So the most amount of trabs are done by the most experienced surgeons. In the other segment, we also got answers by I've been performing trab for more than 20 years, and someone even replied more than 37 years. But for this presentation, I have actually excluded the other group because putting the filters in was quite difficult for each answer. So what I did now, at this point, after seeing these 2 questions, I put a filter in, and the filter took the regular trab performers and the senior trab surgeons. That it wanted to see that how many of the senior trab surgeons who have at least 5 years of post-grad experience and more than 10 years of experience were doing regular trab. So when I combined that data together, I found we had about 59 answers throughout Pakistan. So now these, and you can see again, situation did not change. Majority, about 80% of the surgeons who were doing more trab or regular trab were those who had the most experience. So it is quite obvious that trab in Pakistan is done by only the senior and most experienced surgeons. And from now on, I will be excluding the data of other contributors to the survey. I'll be happy to deal that on a bigger platform at a later date, but in this presentation, I'll be only concentrating on these 2 groups. And these 2 groups who are regular performers of trab. So, so the next question was that where do you perform the next question to these senior surgeons who were doing regular trabeculectomy? The question was, where do you perform trabs? And you can see very clearly that overwhelming majority, about 67% of them, they perform trabeculectomy in recognized teaching centers, but also look an equal amount, a significant amount of the regular trabs by these senior surgeons is done in private sector, whether it's a hospital or a clinic. So what does this mean? That this means that these senior surgeons who have at least 5 years of post-grad experience and are regular trab doers, they are not only involved in teaching the next generation, they not only have a huge responsibility on their shoulders for training the next generation surgeons, but they are also responsible for treating the elite and the richer populations. So you're dealing with the training of the future generation, and you're dealing with the people who are influential and affording. Okay, so the next question was, where do you when do you offer the trabeculectomy to your patients? Now, so please pardon there's some delivery van coming to my house. Okay. So the next question was that when do you offer trabeculectomy to your patients? Now, this was a very important question, and at this point, I was a bit disappointed to find that overwhelming majority of the surgeons, of these experienced surgeons who do regular trab, they offer trab very late in the disease process, when at least patient has a progressive disease in the presence of at least 3 topical medications, or sometimes 4 topical, or when the medical and the medical topical and oral treatment has failed, or when the medical and surgical treatment has failed, only then the trabeculectomy is offered. So about 93% of the surgeons offer trabeculectomy to the patients very, very late in the disease process. Now, this has huge implications. That means you are exposing the conjunctiva to preservatives and to the drugs, and you have higher pressures. And these are all the risk factors which are known to lead to the failure of trabeculectomies. For example, it is a well-known fact that within 5 days of giving a preserved eye drop to the conjunctiva, you can have a level of inflammation rises. You can, within 5 days, you can start having subconjunctival fibrosis. You can have fibroblast proliferation of the conjunctiva. The collagen synthesis and interlinking of collagen to elastin in the conjunctival space becomes more. And at the same time, the scar tissue. Sorry? And scar tissue deposition in the conjunctiva also increases. So you can see, this is quite happily demonstrated by this histology. Look at this normal conjunctiva with the occasional goblet cell there, and look at the subepithelial space where there is no fibrosis. Now compare it with travatan. So within 8 days of travatan, this is 8 days of travatan, within 1 week of travatan, you can see in the number of goblet cells. You see one dark orange, purple, and you can see it's now filled with goblet cells. And look at this fibrosis. Compare this fibrosis, subepithelial fibrosis over here. So you are already inviting scar tissue before actually performing the trab. And that's why there are many trials like TAG trial, which actually prefer primary trabeculectomy. Or if you look at the National Institute of Clinical Excellence guidelines, they would say that if the eye drops, if the glaucoma is progressive on 2 eye drops, this is the time to consider trabeculectomy. So earlier than later is the answer. And over here, again, to hone my point, so you can see on this side, you have a fibroblast, and at day 0 of the trabeculectomy, if there is no inflammation, this fibroblast will lead to the contraction of the scleral tissue, of the scleral disc. Sorry. So, but see what happens when you add this macrophage or inflammatory cells to this fibroblast. When you do that, then you can see the contraction is significantly more than as compared to no inflammation. So adding inflammation, so doing doing trabeculectomy later in the disease process means that you are automatically allowing a far more robust and aggressive inflammatory reaction with more contraction. So, which is beautifully presented here by these 2 videos by Penkop. So you can see here the as the time passes by, the contraction will lead to this bleb contracting. Can you see? The bleb is contracting over time, and this is now represented at the same time. This orange is the myofibroblast, and this is the collagen. And you can see this myofibroblast actually has tentacles, and it reels in the collagen, just like on a basant when हम गुड्डी लपेटते हैं अपनी डोर लपेटते हैं अपने हाथों में, बिल्कुल उसी तरह the myofibroblast is actually, can you see, is reeling in the collagen, can you see, and contracting, and that will lead to a small bleb. So inflammation is very, very important aspect of trabeculectomy. And it's a huge topic. The ocular fibrosis is a huge topic, and there is a complex interplay. There's a complex interplay of many different things like growth factors, cytokines, receptors, enzymes, and many different kind of cells like plasma cells, platelets, affecting attraction of macrophages and lymphocytes, then which leads to the cross-linking of collagen and elastin. So all of these things are actually led by inflammation. So this is a very nice paper published by Penkov, and you can actually see that phases of conjunctival wound healing. I'm not going to go into the detail of that, but you can see there are so many factors that a trab surgeon has to consider in planning the trabeculectomy surgery. And these are the things of ocular fibrosis which are only happening in the subconjunctival and subtenon space. So the subtenon and the subconjunctival space is actually a separate organ. It must not be considered just a potential space. It is a separate organ. It has extremely complex microanatomy, and even more important is the biology and pathophysiology of the subconjunctival and subtenon space. So without a robust knowledge, it is very likely that you may adopt surgical procedure, which is not an ideal step. So, so moving further, the next question I asked was what type of traction suture you prefer. And again, it was disappointing to see that about 75% of people were actually choosing spear erectus bridal suture. Now, it is well known, as I mentioned earlier in my earlier presentation, we talk about evidence. It's not my personal, although it's my personal finding too, but we talk about evidence, and everyone knows without a shadow of doubt that spear erectus bridal suture has iatrogenic complications like hemorrhage. And once you get a drop of blood in the bleb, you are actually bringing in a lot more inflammatory response, and that can lead to the more ocular fibrosis, excessive wound healing. And also we know the spear erectus bridal suture offers poor vector forces for the exposure of the surgical site as compared to the corneal. And then this was Cambridge antibody 152 trial, where they were looking at the antibodies to role of Cambridge antibody 152 in the success of the trabeculectomy. They found that patients where spear erectus suture was done, they did poorly as compared to the corneal suture. So corneal suture should be your main way of bridal suture, or to say suture. Please steer away from the spear erectus. And then I've omitted a few questions because I have to prepare a presentation at the last moment again last night. So this question was that in fornix-based incisions, the conjunctival and subtenon, how do you do the subcon and subtenon dissection? So it was very interesting to see that majority of the surgeons, about 68% of the surgeons, only do adequate dissection to do a scleral flap and put sutures in. So if you do just an anterior dissection to do a scleral flap, you're likely to get an anterior overhanging bleb. And when combined with mitomycin C, those blebs are likely to transform into cystic blebs, which then also can notoriously leak. Now, it is a very, very important thing. The leaking bleb, can lead to endophthalmitis, but endophthalmitis in TRAB is very different from endophthalmitis in cataract surgery in phaco. In phaco, the risk of endophthalmitis is 1 in 3,000, whereas a rate of endophthalmitis with chronic bleb leak is 1 in 100, is 10%. So 10 people out of your 100 TRABs are likely to get endophthalmitis if you are creating blebs like these. So, so it is very important that you do not just restrict yourself to the dissection of the surgical site, but you must also do dissection on the either side of the superior rectus and up to the insertion of the superior rectus. I do not suggest to dissect over the superior rectus because that can lead to bleeding sometimes, which we don't want. So the next question was that how do you apply the anti-fibrotic agent? So over here, it was, again, very interesting data. And so you can see the majority of the people, whether they are using sponge or whether they are using injection or they're just using drop or any method of using anti-fibrotic agent, they were they were usually using most of it over the scleral flap or sometimes under the scleral flap. But the area of scleral dissection or scleral flap dissection was the main interest site of application of mitomycin C. So they are applying mitomycin C very anteriorly, and anterior application of mitomycin C means they are likely to lead to anterior cystic blebs, which can cause endophthalmitis other than the dysmorphic symptoms. So only, but at the same time, I was very happy to see that about 44% of the surgeons, of senior surgeons, they have a very good understanding of applying the mitomycin C only posteriorly on the either side of the superior rectus. So the blue sponges need to be applied posteriorly, and this is a no-go area of application of mitomycin C, especially if you are in a habit of placing conjunctiva over the sponges and then wait for 3 minutes. That is a disaster. So this is a video. I took it from YouTube. Some Indian surgeon. The point to note in this video is that how he is stuffing the MMC sponges in the conjunctiva and then places conjunctiva on it while he waits for 3 minutes. So let's see what he does. So you can see he puts mitomycin C in, one sponge, second, and then another. Look how he is, and then he puts his forceps and brings the conjunctiva forward and waits for 3 minutes. Now, this means that not only he is applying mitomycin C to the scleral bed anteriorly, but he's also exposing the anterior conjunctiva over the scleral bed to mitomycin C, a recipe for disaster for anterior cystic blebs. Now, this is the video from Imran Masood, who I think is Noor Butt's trainer and as well as my mentor, and see how he applies the mitomycin C blebs. First of all, see how delicately he picks the tenon and he puts the conjunctival clamp. And see, he's putting the mitomycin C way back into he puts it right there at the end. And now he's taking them out after 3 minutes. But throughout the procedure, the conjunctiva is lifted by the clamp. It is not coming in contact with the mitomycin C. A very, very small, but yet a very important aspect of long-term TRAB management. And if you do it properly, you're likely to get this kind of a smooth, posterior, diffuse, normally vascularized bleb rather than a cystic bleb. So the next step is, how do you create it? Once you've done the mitomycin C, how do you actually create a skeletal flap? So it was very encouraging to see that majority of the patients, about 70%, more than about almost 80% of the of surgeons, they make a square or a rectangular flap. But it was equally discouraging that these about 20% of senior surgeons actually make a triangular flap, which was very confusing because, as you all know, the aqueous flows the path of least resistance. So if you have a triangular flap, the aqueous is going to flow this way or this way. So so you are actually encouraging anterior flow of the aqueous, which you don't really want in trabeculectomy, in modern trabeculectomy. This was something which was done about 50 years ago. This has no role in modern trabeculectomy. So in modern trabeculectomy, you want your aqueous to flow out posteriorly. So the second step is, once you've made the flap, how do you make a sclerostomy, and what size sclerostomy? Very interesting answers. Now, you can see the majority, about 87% of the surgeons, they use a manual block removal with blade and scissors at the corneoscleral junction anteriorly. Now, there is no harm in doing it, but the only thing is that this is a very crude method, because you cannot actually control the size of the sclerostomy. You can actually make a quite big sclerostomy. The ideal size of the sclerostomy is around 0.5, which is 0.5 to 2 millimeter in size. And you can see there are about 8% of senior surgeons who just stick to a very small measured size of sclerostomy. But then there are a few others who try to make, again, a larger sclerostomy with a punch. Now, this gives me an understanding that not enough attention is paid towards the size of the sclerostomy and the aqueous egress. So this is a very nice paper which deals with the shapes and dimensions of skeletal flap and sclerostomy and their influence on the aqueous outflow. So they found that it's actually the square flap with a large flap to sclerostomy ratio leads to an optimal flow rate. Now, optimal flow rate is a very complex term. It's the optimal flow is just the right amount of aqueous to go into the subtenon space to prevent hypotony and to cause minimal fibrosis. Now, all of you know that aqueous is a pro-inflammatory substance. Now, if you allow more aqueous to go into the subtenon space, not only you are likely to encounter hypotony in early stages, but in later stages, you are also likely to have a failed trab too, because especially in those cases where the presenting pressure was too high, or if the ocular surface was quite inflamed. Higher the intraocular pressure, more pro-inflammatory the aqueous is, more cytokines you have in aqueous. That means you are allowing far more aqueous cytokines to go into the surgical site or the bleb, leading to far more inflammatory response in ocular fibrosis. Now, and also in a whole day, out of 24 hours, your eye hardly produces 3.5 milliliters of aqueous in 24 hours. And then you make such a big cannonball hole, allowing almost liters of water to be flowing into the bleb. There is little sense in this. This is just inviting an hypotony. So from hypotony on and from the optical aqueous flow, the next logical question is that when you place the suture, what is going on in your mind? So when you, how do you actually design your sutures? So do you actually design for the posterior flow, or do you actually design for posterior and lateral flow? So here again, I found that about 73% of senior surgeons, they want both posterior and lateral flow, which is not ideal. You don't want anterior flow. A lateral flow means it's all anterior flow that will lead to lesser posterior flow and hence promotion of anterior cystic blebs and tenon cyst. You actually want posterior flow. A very healthy population of senior surgeons, about 27%, actually encourage only posterior flow, which is good. But still, there's a huge need that that majority of senior surgeons need to change their basic concept and should only look at the posterior flow. And to encourage the posterior flow, you have to decide what kind of sutures. You have to put tight sutures, which is absolutely necessary. But you can put a releasable tight suture, you can put adjustable tight suture, or you can put a fixed tight suture. So whatever suture you put in, the predictable trab means that you should be able to control the strength and the tension of the sutures. If you put a fixed tight suture, you will be doing suture lysis with a YAG. If you're doing adjustable tight suture, you will be adjusting it over the post-op period. And if you're putting a releasable suture, tight suture, you will be releasing the suture. Now, ideally, in modern trab, on the day one, due to tight sutures, the pressure is in the range of mid-teens to mid-20s, even if up to 30. And then by adjusting or massage or releasing sutures, you slowly titrate the pressure down to around 10. This is the modern way of post-op management. But to my horror, look at the majority of the surgeons do fixed sutures and loose sutures. Now, with a large sclerostomy flap, with triangular flap, with anterior flow, and loose sutures, that is not trabeculectomy. This was done about 50 years ago. World has moved on, and this is a practice which needs to stop ASAP. So what happens with hypotony? So this is my last case, and it's my nightmare case. So in this case, you can see, so what happened that this patient was very, very anxious patient, and I was very anxious while operating on her because she is a patient who is known to do written complaints. Anyway, the surgery went in a textbook-like fashion. I think I was very, very proud of myself of doing such a textbook-like procedure. And the next day, on first post-op day, the pressure was around 18. I did a little bit of massage. The pressure went down to 8. I asked the patient to sit out in the waiting room area, called her back in about an hour or so. Pressure was still about 8, 9. So I said, okay, fine, I'll see you in a week's time. When I saw in a week's time, the pressure was 28. So this is fairly common. Pressure may start to rise. So I did massage again, and the pressure dropped down to 8. So I called the patient back after about 2 or 3 hours after my busy clinic, and the pressure rose to 24 again. So I took the suture out. So once I took the suture out, the pressure dropped to 6. So I said, okay, I'll see you again next week. So when I saw her next week, the pressure was again 24. So I took the second suture out. So at this point, when I took the second suture out, the pressure did not drop. I did the massage, and it was very difficult to do the massage. There was some blockage somewhere, which I can't see. The aqueous was not flowing out. So I stupidly did more aggressive massage, and that led to ciliary cleft. The bleb didn't form. There was something blocking it. The bleb didn't form, and that led to ciliary cleft, and suddenly the pressure dropped to only 2.323. So this is the OCT scan of the disc, and pre-op, you can see a very smooth RPE, and you can see this is the Brooks membrane opening, and there is very little neuroretinal rim. And this is what you see after hypotony. You can see the irregular contour. So there was clinically, you can see the optic nerve head looks healthy. It does not look swollen. And this is the point I'm trying to make, that when you have low pressure in an advanced optic nerve head, it may not look swollen, but just do OCT scan and compare it with the pre-op. You can see the whole of the pre-laminar tissue, this neural tissue, is not swollen. The optic nerve does not look swollen on slit lamp, but on OCT scan, whatever little neural tissue was left, it was swollen. And it's swollen because of the stagnation of exoplasmic flow against the scleral pores. This is a disaster. Vision fell to counting finger and to this date. And because I waited stupidly for more 2 weeks before going in and repairing the cleft, hoping that it'll repair by itself, the patient is now counting fingers permanently with pressures of 4 or 5. So you can see how dangerous is hypotony. Hypotony is a killer. In post-op, it's good to have slightly high pressures, which can be titrated down to a safe range to 8 or 10, but to have a hypotony is a disaster. This is why in all standards across the world, whether you take National Ophthalmology Data Standard, whether you take PTVT standard or any other European standard, 2 consecutive visits with hypotony, clinical hypotony, is declared as a failed trap. So if you say that after a year or so, your trap that you did a year ago had low pressures of 2, 3 in the beginning, but now it's 8, 10, that's a failed trap, because you've allowed the eye to stay in the hypotenuse state for too long, and then as the blood matured, the pressure came up to around 8, 10. By this time, you have caused irreversible damage to the optic nerve. So how do you do the so that's why it's important to put the controllable sutures that you can control. So how do you put releasable sutures? Now, in this video of mine, I did a mistake of entering the aqueous after making this scleral flap. I made the sclerostomy and then started to put the scleral flap, and I didn't have AC maintainer at this time. So I have to put an air bubble in to maintain the AC and to prevent hypotony per op. But that makes the releasable suture very difficult. So I would suggest to put releasable sutures in before you actually make sclerostomy or enter the AC. So the first step is you pass the needle. There are many different ways. You can make a corneal groove and bring the suture out through the corneal groove. I tend not to make corneal groove because I think that's an unnecessary cutting. And it doesn't really affect the comfort of the patient post-op. So you pass this nylon suture. This is the first step. And the second step, you again pass through the clear cornea. And then you come out, you go through the sclera, partial thickness sclera, and then come out through the scleral flap. That's a step 2. And you can see this loop is made. And this is a loop that you're going to pull post-op to release the sutures. And the third step is you take a full thickness bite through the scleral. Now, you need to take an adequate bite because the length of the bite is directly proportional to the tension of the suture. So you take a full thickness bite like this, and then you throw 4 sutures, and then you throw 4 turns, 4 throws or 3 throws, doesn't matter. And then you tie a shoelace suture like that. And then you make it tight. So again, once you make it tight, you do not want aqueous to be flowing out here. However, it should not be extraordinarily tight. So I repeat again by putting fluorescein. I think I'll put this in twice to hone my point that you should only get a minimal, maybe a tiny drop of aqueous coming out or no drop coming out. But as soon as you depress the posterior lip here, with the slightest of the pressure, the aqueous should start to egress. That is the right pressure of applying the sutures. So no fluid coming out like this, but with slight pressure on the posterior lip, the aqueous should start to come out. Now then, how to close the conjunctival and tenons? It is good to close conjunctiva and tenon together. Sometimes it's not possible, but the majority of times with good dissection skills, it should be possible to close tenon and conjunctiva together. However, if, as the survey says, that most of the surgery is done in very advanced in the disease, with prolonged use of glaucoma eye drops, you get a syndrome called tenon absent syndrome. You may not have tenons at all at that time, which can lead to cystic blebs. I asked the question, how do you close the conjunctiva? The majority of the surgeons, about 52% of the surgeons, they say that they only put interrupted sutures at the end of the conjunctival incision. This was slightly alarming for me, but then there was an equal amount, around 42% of senior surgeons, they actually take extra care. They beautifully put the sutures at the end of the incision, and then they go on putting mattress and continuous sutures across the length of the wound, ensuring a watertight wound. And some of them, they also use corneal groove sutures to ensure that there is no post-op leak, which is very, very important. So this is again a way to close the sutures. So the aim is to close is the watertight. If you just use the interrupted sutures at the end, you may approximate the anatomy beautifully, but that means that the invariably, either on the first day or after that, especially if you've used mitomycin C, you are likely to have leaks through the incision site. And once the trab starts to leak, your success rate dramatically decreases. So the easiest way is you pass reverse needle through the limbus, and then you come back and then do purse string through the conjunctiva and the tenon together. So you can see he's also taking tenon. And then when you pull this together, the conjunctiva approximates very tightly, and the knot gets buried underneath the conjunctiva. It's not exposed and it's not painful to the patient, and being nylon is then slowly internalized. So he does the same thing on that side. It's a courtesy of Mr. Imran Masood. So, and then he passes pursing, taking conjunctiva and tenon where possible. And then when you tighten these, you can see the anatomy approximates beautifully. But then this area is still susceptible to leak. To deal with that, you pass mattress sutures, 2 or 3 mattress sutures. So you pass through the cornea first, and then you pass through the conjunctiva. First pass through the conjunctiva, and then the second pass through the conjunctiva and tenon if possible, and then you tie it. So this space becomes watertight. Similarly, you do the same on the other side. And that brings to my last question, that are you aware of the Pakistan Ophthalmology Database Audit? Also, we call it PODA. This is something that BPOS is offering as free to all Pakistani ophthalmologists who do TRAB. This is the website, ophthalmologyaudits.org. And if you go onto this, you have to register yourself for patient data confidentiality. Once you're registered, you will be able to put in your TRAB outcomes in a cross-sectional and as well as in episode manner. We've been trying to promote this. We also had a webinar by which in detail discussed the ophthalmology audits. However, very few doctors are still aware of this. Majority of doctors are not aware of this. So I will strongly suggest that please do look at ophthalmologyaudits.org and try to put in your data, because as you put your data in, you'll be able to audit your results. And if you audit your results, it's very likely that you can find your weaknesses, and at the same time, you can find your strengths. And if your strengths are worthy sharing with international podium, then Pakistan will also have a very healthy, very nice representation, because I've seen excellent surgeons in Pakistan who do marvelous things, but the world is unaware of them. And even if they try to tell or show to the rest of the world a technique, it's not picked up, or not many people pay much attention to it, because it has not been properly audited against a control. So I'll strongly suggest to start gathering your data and do your regular audits in trabeculectomy. So in summary, the survey has identified following learning needs for experienced surgeons and trainers to perform predictable trab, that they need to pay more attention to the subconjunctival anatomy and pathophysiology, because this is a separate organ, and a better understanding of the engineering models of scleral flaps and sclerostomies, and different kind of flaps and different ophthalmic diseases and systemic diseases. How would you make a flap in a high myope or in a collagen vascular disease? These are all complex things that you need to decide in a very logical and with an engineering mind for traps. And then same about the sclerostomy. What should be the size of the sclerostomy to prevent hypotony, and yet to have a very controlled optimal outflow of the aqueous? And then how does the aqueous behave in different pathologies? Aqueous is a very, very dynamic and complex fluid, and in different glaucoma pathologies at different intraocular pressures, it has different biological things. For example, in a uveitic patient, it may be of a different, it may be loaded with cytokines leading to trab failure. Similarly, after cataract surgery, the reason why we do not do phacotrab, or the reason why we discourage phacotrab, or we would not do trabeculectomy within 6 to 9 months of cataract surgery, is that after cataract surgery, the inflammation persists for around 9 months. And aqueous is very, very pro-inflammatory. So, and there is enough evidence littered all over the literature that if a trabeculectomy is done within first 9 months of cataract surgery, then the function of the bleb is likely to be reduced, or it's going to be less successful surgery. Or if you choose to do phacotrab, the outcome would be less successful than trab alone. Or if you do a cataract surgery within 6 months of trabeculectomy, then again your functional bleb, the function of the bleb may reduce. So each ocular pathology, whether it's a cataract surgery, whether it's a uveitis, whether it's high intraocular pressure, or whether a person has certain genetic diseases, they all lead to very different kind of aqueous properties, and they should be in your mind before doing trab. And then releasable or adjustable sutures to have a controlled aqueous optimal flow, and to secure conjunctival closure is also an unmet need. Thank you for your patience, and I apologize for taking so much of time, but I hope we had meaningful discussion. Thank you very much.
So beautifully explained the basic concepts, and it was really shocking to learn about the trabeculectomy practices, what we are practicing and what modern practices are, the concepts of conjunctiva, the concepts of subcutaneous space, different organs, posterior bleb, and if I summarize in a word, marvelous, brilliant. We didn't know that time hasn't spending, because we were seeing you with open eyes, and we didn't know how much time went. Beautifully explained. So would you like to have some comments? Okay, so because of the time, if I would not take questions at this moment and start with the future program so that we can conclude the ceremony in time, I would like to welcome the next speaker, Dr. Nurbak Nizamani, to please come and please explain us the new concepts, FECO with goniosyncolysis.
Screen share. First slide. Good afternoon, everybody. It's a pleasure to come and present here because this is my other institute, and I have trained here, and it's very encouraging to see the type of service SIOES is providing. I've seen the transformation myself because I've trained here, and it's come a long way. And I think there's a lot more to do. So I felt that I should give back a little bit to my institute just to improve the services here. Dr. Rashida has brilliantly explained about the trabeculectomy and angle closure. So I'll just take the opportunity to build up a bit more about angle closure and the kind of procedures we are doing to treat angle closure. So I'll just take this opportunity to explain more and share my experience about goniosyncolysis. I'll share some cases as well, which I've done recently in treating angle closures. And I think it will be a great help for you guys to learn and develop the skill as well. So I'm not going to go into the details of the Eagle trial and everything, I think, because Dr. Zia has already explained pretty much in a good detailed way. So the main thing is wherever there is peripheral angiosync or PAS, cataract surgery alone may not be sufficient to lower the pressure. And most of these patients, we know that they are already on maximal treatment and all these things. As we saw a few cases that myself and Mohsin performed the other day, we did gonio intraoperatively on them, and even after the removing the cataract, the angle was pretty much closed. So we have to do a touch bit more alongside with cataract surgery to open up the angle. So and that's where goniosyncolysis, or GSL for short, comes in place. That is like a physical disruption of PAS, which we physically open the angle to lower the pressure. So as you can see this, there's PAS in both of these slides. This is again a gonioscopic view. My message, I will just give it right now as well, and I'll keep stressing on it throughout my presentation, is you cannot do enough gonioscopy in your lifetime. Keep doing gonioscopy. You have to do gonioscopy on all your glaucoma patients. At least once a year, patients should have a gonioscopy, regardless of their type of glaucoma, because it's very dynamic. The angles are dynamic, they keep changing. So do as much gonioscopy as you can. So this is how how PAS or peripheral anticyanical looks on in an angle closure patient. The patients we operated on, there was literally nothing visible on gonioscopy. They were zipped closed angles. So unless you do gonioscopy, you won't be aware of what I'm talking about. So the more you do it, I think even that is less. So just keep doing gonioscopy as much as you can. So basically, as I said, GSL is a method of opening up the angle physically by separating the PAS from the trabecular meshwork, either direct or indirect visualization. It has been in clinical practice for many, many years, but people have not been doing it enough. It's recently gained more population after these EAGLE trials, and then people thought, what's happening? And they started doing follow-up trials on these things, and they found that although EAGLE trial promotes lensectomy and cataract surgery, but that was not enough in these type of patients who have got peripheral anticyanicia. So we have to do more. Even cataract surgery itself is not sufficient in these kind of patients. So indications, I mean, 90 to 80 degrees or even 360. I've done GSL on a variety of patients. And I think even if there's a tiny bit of PAS, I would do GSL on that patient. I mean, it hardly takes 5-10 minutes more in addition to the cataract surgery. So there's literally no harm in doing it. So any amount of PAS, I would say, do the GSL along with the cataract surgery. And it's a variety of patients, as you can see, acute, subacute, chronic angle closures, even secondary angle closures. We've done a big study with Mr. Masood on secondary angle closures, like post-vitrectomies, post-DELC, and all sorts of other combination of patients. And it works beautifully in all sorts of patients. So any type of angle closure with PAS, even in Plateau Iris, we've done all these things, and it really helps. And you'll notice in my case series that the patients we treated had their iridotomies and other stuff done as well, but regardless of that, they were not having a good pressure control. So there's a lot of misconception that PIs, as he said, a lot of people don't even do PIs anymore. They just go straight and do cataract surgeries. But my point that I'm trying to stress is, if there is PAS, cataract surgery may not work enough. It may be helpful, but it won't be sufficient enough to give a good pressure control. So we have to do something more, and the something more is where GSL comes into action. There are a lot of different types. These are just like the big fat types that I've taken out. So there's a conventional way where we do it like we do most of our mixed procedures. That's the direct visualization, but that is quite a tedious process because you have to tilt your microscope, you have to tilt the patient's head, then you need a special type of lens, and you yourself, or it needs a lot of, it's a big learning curve to adopt to this conventional method of doing it. And the biggest hindrance that I find, I do mix, and I do a lot of mix in this procedure, in this way, but there is a sort of limitation. You can't do 360 degrees of GSL in this way. Then you have to keep tilting the patient's head. You have to keep turning. That's a very long, time-consuming process. And what I found in my practice is the longer you take during your surgery, the more inflammation you'll end up afterwards, and that can be disastrous as well. So then there are different types, like a modified endoscopic version, but again, most places don't have that endoscopic facilities. I don't have it at my hospital as well, so that's also very limited. Only limited about type of people can do it. Some Chinese studies have done it on the slit lamp, which I don't advocate. I would recommend nobody does that. The Chinese can do a lot of weird things. And one of them is this, they started doing this on the slit lamp. Please don't do that. You can make the patient blind, so don't do that. So the version that I do is I did a single double mirror gonioscopy lens, which is basically an indirect lens. So you just finish your cataract. I'll go to the method in a minute. But this with the micro installation around microforceps, You can easily do it right after your cataract surgery and without tilting the patient or yourself or changing the microscope. It's very easy, straightforward, and less time consuming. It hardly adds about 5-10 minutes to the procedure. So this is the last one is the way I do it without changing anything. You just directly put the lens on the eye and then just do it yourself. So I just covered the contraindications. Obviously, if there is any neovascularization of the iris or this chronic or recurrent uveitis or iridocorneal endothelial syndromes, you should avoid doing ESL in these conditions because you'll end up having more problems afterwards. So what I normally do is, as most of you saw the other day when we did the surgery, after finishing the cataract surgery and implanting the lens, I do an eye move on the viscoelastic. Then if we have a myotic like myocol, I inject that intracameral, wait for the pupil to constrict. That just adds, it makes it easier, makes the surgery more easier. And then I usually use a cohesive viscoelastic like Helon GB or Helon 5. Here we use Viscot because Helon GB wasn't available, but that worked fine as well, as long as you have a cohesive viscoelastic. That really helps. And what I tend to do is when I'm injecting that with that cannula, because we know that even with the Viscot, you can open up the angle a tiny bit. So when you're injecting that, I'll show you a video afterwards what I'm doing as well. So you can just tap with the cannula. You have to go right in the periphery and inject the viscoelastic and tap with the cannula. But that opens up the angle a touch bit and makes the rest of the procedure more easier. Then I use a single peritoneal lens, but this is indirect, so that's a bit of a learning curve because your eye is looking at the lens and your hand is going in the opposite direction. So that takes a bit of time, but I think most people adapt to it very nicely. Mohsin did a very good job. He did some cases afterwards with me, and he easily adopted with it. So I think if you're a good cataract surgeon, if you can do a good gonioscopy, you can easily adopt to this method and do it. So I normally use a micrograsping forceps. These are like VR forceps used for island feeding and other things. So I use those 23 or 25 weights depending on what I can get, but mostly 23 works well as well. So what we normally do is we just go with the forceps and grab in the periphery and pull centripetally, and that's it. That you can physically see the sanity going away and the angle opening up widely. So we will get some views of Mohsin at the end who did this, and then you'll be amazed how much you can open up the angle. Some people tend to make 2 or 3 incisions going from different directions with different hands, but I operate temporarily, and I think I can do it through my one incision as well. So the more you do it, the more you can adopt and create your own ways of doing it as well. So I find that I can easily do it through one incision, and I think the less openings, the better. So your surgery should look like afterwards you have not operated on the patient. So that's my idea of it. So the less manipulation, the better. So that's briefly how we do it. So you can see over here, this patient has had a PI as well previously. You can see so that's the micrograsping forceps, and we are literally grabbing it and just pulling it towards the center. This is just a picture of it, small. The complications, you can get some hyphema, but obviously the more experienced you become, you know how much force to apply, and you rarely get hyphema with it. Even if you get a bit of hyphema, you just inject some viscoelastic and just wait and hemostasis. You get it stable hemostasis, and that will secure it. Iriditis is quite rare. If you're a very clumsy surgeon or you're too enthusiastic and pulling the iris all the way, then you can do that as well, so causing more problems. Inflammation, we always get inflammation, so I tend to get loads of steroids post-op. I usually follow a regime of 6 times a day, and then I see them first week and see how much the inflammation is. Depending on that, then I taper it over the next 4 weeks or so, and they usually do fine with that. Fibrinous uveitis as well, if there are some predisposed risk factors. And in those cases, obviously, I would suggest giving more aggressive steroids and for a longer time. But most people do really well, and they don't need a very long long-term steroid treatment. Some pearls, a lot of pearls, busy slide, but I'll just briefly touch them because I think we're short of time. So pressure control is very important. The reason being your cornea should be clear. You have to have a very good view in order to do a good GSL. So you can give IV mannitol or Diamox preoperatively so that your cornea is sufficiently clear. Again, it should be performed under direct visualization. Especially, I would suggest whoever is starting to do it initially in your learning period, try and do it under direct visualization. But what I have started to do is, I even do it now without the lens because you're in a busy list and you have to finish it. And I think I've adopted so much and done it so frequently that I know exactly how much pressure to apply and do it. So it is much faster. I can do it in like 5 minutes. But the most important thing is you should do gonioscopy. After you finish your phaco, do a gonioscopy and see how much angle you can see. Then do your GSL, do another gonioscopy intraoperatively to see how much it has opened. And if I'm happy it's open 360, that's the end of the case. So I've done this. This is my modified version of doing it. I can do it without visualization as well. Some people, if you don't have the MST forceps, they use Utrata forceps, Pepsirexis forceps, or even McPherson's. There are very different variations in this. But the only thing you have to be careful is you should not cause any iris damage during the procedure. If you damage the iris and cause bleeding and all that stuff, then you're going to end up in more problems afterwards. So you just have to be careful and work with your choices. Also with the dilated pupil, that's why I mentioned Myophor or Myostat. So I tend to use that quite frequently in my patients. Again, viscoelastic, I mentioned this point. It can also differentiate. Important thing is it can differentiate between an appositional angle and a synovial angle closure. So what will happen is when you inject the viscoelastic, for appositional it will open up, but with the synovial it won't open. So that will also give you an idea that how you have to actually do the GSL. And I think that was one of the things that was not highlighted in the EAGLE study, that maybe a lot of them were appositional and they did really well with the density and cataract surgery. But if you have a significant past, cataract surgery will benefit, they will benefit, but not to that level. Again, second incision, some people do it, I don't do it. But it's entirely up to you. There's no harm in doing a second incision if you want to do more, you know. Again, GSL combined with MIGS, I've started doing that. Some people have a lot of reservations on this, but I feel that if you're confident enough in opening the angle significantly and then you can do MIGS after the GSL as well. I will highlight this in my case in future slides. Also remove viscoelastic, which I think we all do after cataract surgery anyway, so to avoid any spikes. This is one of my patients, Asian patients, dark iris, very difficult to even see the gonioscopic view, but you can appreciate that first it is totally closed, although some people, that's why I'm saying the more you do gonioscopy, the more you will realize what's happening. So this is before the GSL intraoperatively. It's all closed. And here you can see that it has opened up significantly, and you can see it's an open angle there. This is another one. Nice twice, so you can appreciate a bit more on this patient. Again, you can see the
सेल्फी फिक्सेशन देखिए थोड़ा सा ज्यादा करना है देखो सब कम है ये भी कहाँ तक करें ना बी के कितने
Sorry for that. Next. Yeah, that's right. So this is another patient. You can see the microgastric forceps resting on that. That's the before GSL angle, which is closed, and then the after one, which is quite open there. So I'll just share a few cases very briefly, just to highlight the importance of GSL. My first case is a 70-year-old female who presented with acute angle closure, maximum pressure of 73. She had a PI. So usually when we get these patients, they go to emergency clinics and they are initially managed over there before they are referred to me in the glaucoma clinic. So after that, she was referred to me. When I saw her, her vision was counting finger at a pressure of 14. She was obviously on 4 drops at that time. Angle was zip closed, Antonio. So I did a phaco GSL for her. To my surprise, her vision also improved to best 269, although I told her about the prognosis. Sometimes these patients just amaze you. And then pressure was 10, wide open angle, and we eventually stopped all her drops, and she stayed on a pressure of 10. So she did really well in that respect. Another patient, young patient, 56-year-old male, he was a hyperope with accidental closure again, and he had a PI initially managed by emergency clinic and referred to me. When I saw him, his pressure was 68 on 2 drops. And then we did a similar thing for him and a similar outcome. His vision also improved to 6.5 on 0 drops. He's doing quite well. Thank you. So third case, 71-year-old female, again, acute angle closure with CRVO, hyperope patient, 58 pressure. She had a phacomorphic element as well. So again, when I saw her, she was a pressure of 58 with 5 drops. She was even on pilocarpine, but no use. Zip close angles, counting finger vision. Guided prognosis explained to her and explained clearly that we are doing this just to control her pressure. And she did quite well. We managed to reduce her drops to 3 drops, and then angle was wide open, pressure was 14, but obviously visual prognosis was already poor, so she did not do too well in that respect. Fourth case, this is interesting. So this is one of my patients who had a trabeculectomy a long time ago by someone else, and he was on 5 drops, including pilocarpine when I saw him. He had a bit of cataract, and then surprisingly, he hadn't had a gonio for a long time. So when I did his gonio, his angle was totally closed. And then I said, well, let's do this for you and see how it goes. I had explained to him that, see on the drops because he had advanced glaucoma and he had trabeculectomy in the past, which didn't work so well for him. And we did that for him, and he did really well. His vision improved to 6.9 and pressure came down to 10. Angle widely open, obviously, and we managed to stop 2 of his drops, and he's on 3 drops, and quite well. So he was quite happy in the sense that he was telling me he had been in a routine of doing so many drops now, but now he's quite happy with this outcome. So the important point is even in post-trap patients, in secondary angle closures, if you get a situation like this where you're about to do a cataract surgery, do a gonioscopy and see what's happening in the angle. Without looking at the angles, I think I would be blind because I cannot make decisions. Even in any type of glaucoma, if you know your angles, you see your angles, that helps you to decide and make a better decision for the patient. So last patient is quite interesting. She's an Asian patient, 60-year-old female with advanced glaucoma, referred to me by another consulting colleague for trabeculectomy. But she had a lot of drop allergies as well. She was already pseudophakic, as she was unwilling for a trap. She simply said, no, I don't want any trap. I'm allergic to so many drops. And then afterwards, whenever talking to a patient about trabeculectomy, I sit and talk to them for 15, 20 minutes, explaining to them that trabeculectomy will be the start of the journey. It's not the end of the journey. 3 months, they have to be committed with whatever I tell them to do. So it's a long commitment, and she was not willing to take it. And then I did the gonio again, and then angles were closed and said, well, let's do a DSL and mixed procedure for her. She was quite happy with that because she said, oh, it's just a 30-minute procedure, I'll be very happy. We went ahead with it. I did the GSL, angles opened nicely, and then I also injected, put an eye stent in there as well, just to give her an added benefit. Because obviously I know she's not going to go for trap anytime in future. So, so this was her final visit. On the first visit, her pressure dropped to 6. So because she was on a lot of drugs, you know, somebody had put her on Dinox as well for STD. So I did stop all of that eventually. And then her pressure settled at 11 with 1 drop only. So she was a very happy lady at that. So this is what we need, and that's what I'm stressing. If you don't do enough gonioscopy now, most people would have seen a good pseudophakic patient and said, "Oh well, she's a pseudophakic patient. Why do we need to gonio her? She's going to be open angle anyway." It's a myth. It's an assumption. So please don't go by these things. Even if the AC looks deep or if the patient is pseudophakic, you can have angle closures. You'll be surprised the amount of angle closures you see when you start doing gonioscopy properly. So my message, my take-home message is gonioscopy, and gonioscopy. Do as much as you can, as often as you can, and for these type of patients which you are choosing for GSL, I tend to do it preoperatively, intraoperatively, and by postoperatively, obviously, but even during the surgery, when you finish your phaco, do it once, then after you finish your GSL, do it again, see if you've done enough. So if there is a CHAS of greater than 6 clock hours, preoperatively, GSL should be done. I do GSL for any amount of CHAS, as I said. If I'm doing a capillary surgery, I mean, why not give the patient an added benefit? There's no harm in doing it. Furthermore, if there is still CHAS of greater than 4 clock hours after the lens removal, again, you do need to do the GSL to give the patient added benefit there. It's a very safe and effective procedure, as I said, in treating angle closure, whether it's primary or secondary, and also reducing medication use, as you saw in my example. So these are all my messages, and that concludes my presentation. If anybody has any questions, then we will take some views from Mohsin as well, who has done a few cases with me the other day. Sorry? Oh yes, I have a video as well. Yes, so. So this is, I've finished the cataract surgery in this patient, and then I'm injecting the Helon GV as I had explained to you. Then some more viscoelastic on the cornea. This is the gonio lens that I use, the Diex one. You can see, appreciate that the angle is all close. You can't see any structures there. I did use myocol in this patient, but sometimes it doesn't work. Well, yes, but you can appreciate that there's no structure visible. It's basically a zip closed angle here, even after phaco. So now I'll show you my forceps that I use, the micrograsping forceps. This is the MSD forceps, 23 gauge. And then I've gone in and I'll grab the iris from the periphery and just pull it centripetally. And you can see that. And it's opening up the angle. So you can see that. Oh. Pause for the take. So we'll play it again then. Yeah. if we started this again, I'll just forward it a bit. So the first one, you just grab the peripheral iris and pull it towards the central there, and then also there's another important thing that you don't have to do it 360. You don't have to go after every sign lesion that you see. Even if you do more than 180, I think that's sufficient enough enough to do. But most of the times, as I said, if you do it often, then you're able to do it 360 as well. It's quite easy and very efficient. So I'm just trying to do as much as I can. Then I did a 1 second. So as you can see, I'm just from my main incision. I'm just manipulating with my wrist and going all the way and doing it in one go. So these bubbles and these things, you adapt to them. You stop worrying about them and you just have to finish the case and just go ahead with it. So. So I'm again just doing it without the lens as well, which I was telling you before. So this patient was quite wobbly, as you can see. She was under topical as well. Okay. So she was moving her head and everything. So I said, well, let's just do it without the lens and do it quickly. Mostly I do all my surgeries topically, but if the patient is more, not uncooperative or something, then I do subcutaneous for them. It is, yes, that's true. But most of them do quite well with it. Nothing special, just lidocaine present. But yes, you're right. If I feel like the patient is a bit sensitive or something, I pick up something else. So I think it just.
This time you are not happy with your
Huh? Sorry?
By this time, this was good. I'm not seeing so much debris in there.
No, you will see it will clear up. Don't worry.
Yeah,
It will. It's. You can see it's open now compared to the first one when we saw that we couldn't see anything at all. Although this is a very dark iris, this was an Asian patient, so you can not appreciate too much, but you can see that from when I showed you pre-operatively, you couldn't see any structure. But now you can see more. Obviously, when I was seeing it, the quality of the video is not so good at the minute. But when I was seeing it, you could see it. It was wide open there, and then. You can see more structures compared to the ones that I showed you pre-operatively, becoming more visible now. Okay, so we can take some questions now. Somebody has a question.
Yeah. Last question.
Yes. That's why I said you treat the corneal edema pre-operatively.
But just like it's like pre-operative.
But the cornea was obviously there. Anyone else? If there are no more questions, I would like Mohsin to come and share his views on this as well, just for 5 minutes. Because the other day, you guys saw the live surgery of Graham and the GSM, but afterwards, after everybody left, we did 2 more cases. Mohsin did a brilliant job. He did 2 cases under my supervision for FIGO DSM on similar patients with angle. So I'd just like to know his views and tell us a bit more how his learning experience was.
Thank you. And regarding those cases together, and on very high
and explain the concept. Previously, we used to have that when angle is the glaucoma is frequently, and you can see the depth of the angle, which we have used when the angle is open. But by seeing Goldman Equation, that was new then. And our perception was seen. So the day to learn, the message of the day is do not assume open angles. Do gonioscopy. And angle is a dynamic structure. It has to be changed, and it is changing day time and time. So you have to do repeated gonioscopy. So before that, after emulsification, angle was used by a simple procedure, took 5 to 7 minutes, and it opened beautifully. I could see terminal measure, even I could see plus as well. So it was very, very wide and open, and it was just beautifully. I could see both his reading. And then
What is planning to use?
we took help from VR and we took VR process, and it works the same. VR process, and we took periphery of the iris. It just had some reading points in the middle. In 50 degrees, I got 4 reading spots only. We stopped with the help of stop, and we opened and reading the data.
You want to do it properly. I haven't said anything. As I said, you call it, but otherwise, it's a very forgiving and nice procedure. Somebody was asking about the lens, so I had brought a direct indirect gonio lens with me. That was a disposable one, but they are quite easily available, quite affordable. There are also some reusable ones which can be bought. Sorry? I'm not sure. I don't know. I brought one with myself, so we just use that surgical gonio lens. It's the similar one that we showed in the video. Okay. So I think you learned something, and the next time I come here, I'll get more gonioscopy people. Okay, thank you so much. Thank you, Moshe. Thank you.
I'm thankful to Dr. Noor for this wonderful presentation. Sorry for the technical details that about the video was not being shared. So we could share the videos in the next session as well, after the next session. Now, I would like to ask worthy Professor Khalid Iqbal Talpur to please come to stage and please inform us new thing about new paradigm shift about interventional glaucoma. So please come to stage.
Thank you very much indeed. And wonderful, excellent talks. Now, what these two talks was the practical management of the glaucoma angle closure as well as the open angle about the trabeculectomy, which Dr. Rashid was talking about. Now, I'm going to talk about what the people are thinking about the future. It's not what we are currently doing, but we should know that what the people are thinking about the future and how the things are going to set up regarding the management of the glaucoma in the future. And this is what, because recently I went to last month to USA, attending the ACRS, where I found some important topics over there. And this is what I thought to share with you, that so that we should know that what the people are thinking about the future. So the term interventional glaucoma was a new term for me. Actually, I didn't know about it. What are the people? Then the people went there and saw a lot of people talking about the interventional glaucoma. So I thought, let's give you some idea that what it is and what the people are thinking about. Yes. Now, glaucoma, we all know, introduction, leading cause of global irreversible vision loss and blindness. It is expected that 100 million people will be affected by 2040 by the glaucoma. The screen is on. Okay. We all know optic neuropathy is the characteristic feature, and there must be cupping in it, because there are many times we feel that there is a pale cup, and many of the doctors label it a glaucoma, start anti-glaucoma therapy. Cupping is the must feature for the glaucomatous optic atrophy. We know it's the dying ganglion cells which lead to the optic neuropathy. IOP is the major risk factor, and it's the only factor which is treatable at the moment. So what the treatment of the glaucoma is to control the intraocular pressure, and we know these are the three conventional methods which have been going on since so many years, so many decades, in fact: medical, laser, surgical. Now, these three treatments, because I have been, in ophthalmology, I've been in UK from late 80s to early 90s. There were different practice at that time. Then in 90s and then first decade of 2021, there were different practices, 2020. And now so things have been dynamic. Although there have been only these things, still there are only these three things, methods of managing glaucoma. Still these three methods: medical, laser, and surgical. They are still there. But they have been dynamic. They have been changing with the time. Their time have been changing. So when I was in late 80s or early 90s, at that time, the medicines to treat the glaucoma, there were only few. There were only few, like pilocarpine or just beta blocker as started. That was introduced. So at that time, late 80s, there was a major, study published in Glasgow. I forgot about that famous glaucoma consultant. He published that the trabeculectomy surgery is better than the medicine, and early surgery should be carried out, rather than starting on the medical therapy and waiting for the medical therapy for the IOP to go up and then going for the surgery. They say that it's wasting time and we are losing the patient's vision, and early trabeculectomy should go. Then in the 90s, new medications started to appear, particularly the prostaglandins and the carbonic anhydrase inhibitors and the alpha antagonists. So many these agonists, these medications started to come. Then there was again change. Why? The trabeculectomy had its own complications. You saw there's so many complications: the hypotony, undercorrection, IOP not being controlled, infections, and then reoperations, many problems. Then once these new drugs came out, again the things changed. People started to put on the medical therapy, and they thought that, okay, continuous medical therapy, and because they are better than the complications of the surgery as compared to that. Then what happened afterwards, that once the patient went on the medical therapy for 10 years, in 2020's first decade, they started having problems of the medical therapy. And what was that? Compliance. Major factor in managing the glaucoma. You gave patient 2, 3, 4 medications. You don't know patient medications are at home, whether they are putting it or non-putting it. Patient is coming to you for IOP checkup after 1 week or 1 month or 2 months, only seeing that. And they started having this problem, the compliance, and people started losing the sight with that. So the medical therapy, these three, it has a very issue of the compliance. That's why Dr. Noor was saying that even if the patient has got now advanced glaucoma, you do goniosynovitis, bring the patient's number of medications down. If the patient is on 4 medications or 3 medications, and with other added, the added method, if you bring that medication to 1 or even 2, that is beneficial than having a patient on medications, 4 or 5 or 3 medications. You'll be in a better position doing that. So this is how it is: the compliance, cost, topical and systemic side effects. These are the problem with the medical therapy. Though the drugs are quite very powerful drugs now, medications, and also some of the drugs, because of these topical and systemic side effects, the preservative-free also drops came out, but not all of them. So that problem issue with the medical therapy. Laser, when I was in England, we used to do ALT, not SLT. At that time, we used to do a lot of ALT, particularly the people who were not fit for the surgery. They had heart problem, they couldn't. At that time, quite a few surgeries, late 80s and 90s, when I entered cataract surgery, some of the places was being done under general anesthesia. When I went into the practice in UK, you know, here now you are doing topical anesthesia at that time. So the laser was at that time ALT, organ laser trabeculoplasty. But now better SLT has come up, and Noor has got a lot of experience. I thought if she had a time, she would have, you know, told us a lot about SLT. It's a new thing, probably she is doing it. So laser had a limited use, but now SLT has come up, and that is part of the interventional glaucoma I'll talk about. Surgery, you saw 2 speakers, they told you about the surgery, how many complications she met. Those both of the speakers mentioned. Though they are trabeculectomy is the gold standard, is still gold standard for the management of the glaucoma. But you see all the complications, they are there. They are sight threatening sometimes, you know, and there are quite a few risks in it. So those are the problems with the trabeculectomy, that you have got that. So surgical, you have 2 trabeculectomy and drainage devices. These are the 2, you know, options you have got in a surgery for glaucoma, and they result into complications and reoperations. Now, all these 3 things now had led people to think about something else. How we can overcome all these issues. Because they are so. Glaucoma is a long-term disease. It goes for decades, years, and you have to save the patient's sight and ultimately the quality of the life. So now, what they thought about is intervention, that we should intervene. Now they are thinking about that rather than keeping the patient, our conventional method of treating was start patient on medical therapy, 1, not controlling 2, not controlling 3, not controlling 4, and then not controlling organ laser or the laser therapy, and then not controlling, go for surgery. This is our conventional way of method. But now people's thinking is changing. Okay. So now that intervention is going on the basis of like interventional cardiology and interventional radiology. You know, interventional cardiology now is very common and people are using the angioplasties, quick, fast, chain, early treatment, save patient from going into bypass surgery, and also saving the patient from having a lot of medications. Early stenting, quick, put the stent on the coronary arteries and block them. Similarly, we are going to use a stent in the glaucoma. Okay, so this is similarly intervention radiology in abdominal pathologies. We just inject the needles and do all the treatment in the abdomen rather than opening up the abdomen. So now this is on that basis people are thinking about this term. What is that called as? Interventional glaucoma. Okay. Now, what does interventional glaucoma is? It's a new way of thinking. Because modern technology is available now, new things have come up. People are thinking new way of thinking of managing glaucoma. You know, and then early intervention rather than waiting for patient giving medication and then laser, then patient's cupping is going to 0.8, then you are going for surgery, waiting for that time. By that time, patient is, you know, how much vision patient is losing. This is how the thinking is changing now again. So what the people are thinking about, new way of thinking. How? Because of the modern availability of modern technology, and thinking of early intervention because of modern technology, and safe and efficacious process. You will only do surgery early comparing its efficacy and safety. For example, you used to do cataract surgery, extracapsular cataract extension. 80s, 70s. What used to be the indication? When your vision is too much lost, then you go for a surgery. Now you have got a phaco. 3.2 millimeter incision, 2.7 millimeter incision, even less than 1 millimeter, less than 2 millimeter incision. Your surgery is safe. So you are going for surgery early as compared to waiting longer life. Because you want to give quality of life patient early. A patient's vision, you have to give him good patient vision at the age of 50, rather than to wait for 10 years more and come back after 10 years and have a surgery and you are wasted 10 years patient life. So this is how it is that your timing of surgery is related to the safety and efficacy of the procedures. If your safety efficacy is much better, you will go early and give patient a good quality. Yes, why not? You are seeing blood. Okay, doctor will say, I'm seeing, okay, it's all right, it's blood over there. But blood is also not quality. Everybody wants to see clear. You want to see clear. Because your all activities, your surrounding activities of your life, they depend upon your vision. How good is your vision? So if you have got, and you will only go for a surgery if you are sure that my surgery is going to give this patient good results. You will go for it. Why to wait for it longer time? So this is what is interventional glaucoma. It is not what you call it a kind of surgery or what. It's not a name of surgery. It's a new way of thinking about glaucoma, how to manage it. All right? And this is going to come up. Now, what are the new procedures? Now, this has come up because the new procedures have come up. New way of managing glaucoma have come up. And they are safe, efficacious, and you can give patient guarantee that yes, a good safety, that yes, like cataract, you can say patient to, like now we are doing cataract surgeries nowadays called as refractive cataract surgery. You are not only removing the cataract and putting IUL, but simultaneously you are treating refractive error, hypermetropia, myopia, or astigmatism. Similarly, you are treating presbyopia at the same time while doing cataract surgery. So you are giving patient, a kind of, new procedures have come up and you will give a patient a new choice. So new procedures have come up in glaucoma. They are in medical intracameral biometacrossed SR. Means drugs we are putting all the time on the drop cornea, you know the problems. no need of describing to you that what these drug put with the ocular surface. I'm surprised, Dr. Zia telling that after 1 week of starting drops, the fibroblastic activity starts. This is what I heard earlier today. I learned today now. You start these drops, these BAK in it, fibroblastic activity starts within 1 week. All right. So imagine 1 year treatment, 2 year treatment, what mess we are creating in the conjunctiva. So, number one, the medical treatment, new thing has come up, that is intracameral bimetoperost SR. People have thought about it. Why not to put a long-term some implant? This has come up, when we inject the dexamethasone implant in chronic uveitis in the vitreous cavity. They live there, they stay there for a long time to control the RIT uveitis. So this is how the people came up. Why not to make a drug which can be injected in the eye inside, stay there, slow release, and the IOP control, sustained release 24 hours for 1 year. So this is a new thing, which people call it interventional glaucoma. They use it. Laser. Dr. Noor probably doing a lot of SLTs. I think you are doing a lot of SLTs. Primary treatment. Now, what has happened? I used to do ALT because at that time SLT was not there. And unfortunately, we are not doing any laser here. Yes. So what? Rather than starting medical therapy, a patient is coming to you with the IOP, say 22 or 23, early cupping. You do SLT rather than starting medication on the medication therapy. SLT is going to bring they compared that the very, very early stage IOP, SLT IOP lowering effect is same as one drug. Yeah, I don't know the trials, but you know it. Well, at the moment we are talking about open angle. We have set aside the angle closure. In this case, we are in this presentation. We are talking about only open angle. We have kept set aside the angle closure. Okay, selective laser trabeculoplasty. The new thing, which is latest thing, is MIGS, which she has already started doing. MIGS, the micro incision glaucoma surgery, or some people call it minimally invasive. I don't know. In America, people are now calling it micro-invasive, micro-incision. But this term, there are two terms. You people are still probably calling minimally invasive. So minimally invasive or micro-invasive glaucoma surgery. It's same like converting from extra to precoimal. If you compare it. It's same like VR people converting from 21 gauge vitrectomy to 27 gauge vitrectomy. Same like that. So your trabeculectomy, you saw how much incision, trauma, surgery, destruction, mitomycin C, how much tissue manipulation we are doing. Similarly, extracapsular, how much incision you are making, and then how much trauma you are causing to the eye. Similarly, VR people, 21 gauge vitrectomy and now 27 sutureless, how eyes are white. You VR people, you know it. Yes, what's the differences? Similarly, now glaucoma, people are thinking about this trabeculectomy, valve implants, and all those things turning towards mix. Although it's in early stages, but this is the trend is shifting. Like the other specialties, cataract, phaco, extra to phaco, VR, similarly everywhere. So these are the three procedures, new procedure, latest, which are coming out. Now let's talk about individual one first. The intracameral bimetopros, it is already, भाई allergan वाले people, ये आपकी नई दवाई आ गई है, अमेरिका में ऑलरेडी इस्तेमाल हो रही है, FDA approved है, I don't know whether, is it in UK? Limited prestige, yes. So it's already for last 1 year, it's in USA, it's being used. This called as Duresta, this Allergan company, and intracameral bimetopros. So this is, it is already, you know, this is this drug, this is the drug, which is already comes in this needle, in this syringe, and this is a sterilized syringe, and similarly like other, you know, intracameral injections. So this is, with the time, it slowly dissolves, and it lasts for about 6 to 7 months. It dissolves, and then its effect lasts for 1 year nearly. Video, please. Just to show this video to you. Next up. No, yeah. No. Yeah, yeah. Yeah. Which one I have? Video. No, he I have video, Baba. Muto kichai in my video which? Yeah, kane. अच्छा हमें लगा है डायरेक्ट लग गई okay, now you see this. This was the needle of that injection. You go into the anterior chamber, leave it there, bevel up. Not bevel down, inject it, and that goes down and it stays in that 6 o'clock. That's it. Okay, so this is intervention that if you are starting medication, you intracameral Lumigan or the bimetopros, SR, inject it, its effect lasts, because you start patient on the monotherapy, that is the prostaglandin, and this is the prostaglandin, save patient from drops, put it on, patient goes home, and that's it, it comes for the IOP checkup only. What people say in USA that now IOP control, as far as the medications are concerned, take away from patient. Patient is not going to use, this is compliance, they are not going to use the medications properly because of the problems. Get it under own control, doctor's control, with the medication, with laser, and with surgery, rather than depending on patient. Right? So this is the new thing. Now let's come to that was about medical. Now let's come to the laser. Now SLT, selective laser trabeculoplasty. Previously it was ALT, argon laser trabeculoplasty. This is the difference. SLT has got a small, you know, very, very focused. It's the spot size is 50 micron. When you do PRP, you use about 500 micron size. Here you use 50, like DME. In DME, you use around 50, 100 micron. So this is 50 micron here at the junction of the non-pigmented and pigmented trabecular meshwork. This is SLT. It has a large size. You apply on the trabecular meshwork, and in early stages, as effective as medical therapy. Early stages. So rather than our way of previous was that put on the medical therapy, early patient coming, as Dr. Noor is saying, to do the SLT. Rather than putting on the medical therapy. This is interventional glaucoma. This is what is, people are giving new concepts about interventional glaucoma. That our conventional way was just putting on the patient, comes IOP high, medical therapy. So this is another way of doing. So large straw, double frequency and non-thermal effect, and it's very good. Next time when you come, please. Other thing, I also want you to teach gonioscopy to our residents. Proper way of doing gonioscopy. Next time when you come, so keep these two in the mind. Next time the laser will be there because we don't have SLT, but still, I'm thinking about that we should have SLT. Yes. Yeah. Yeah. So we'll have a SLT as well next time in this. Okay, next. Hello? Yeah, hey, Maslo. कौन पे वाले? So now let's come to the surgery. So what is new things you have got in management? Bimetocross SR, SLT. SLT though a little bit older, not that, but still is making, and we are not using it. And I don't think many using in Pakistan either. SLT in our country. I don't know why, whether it's what, but there should be something. Now let's come to the new surgery, which is, that is micro-invasive glaucoma surgery, MIGS. It is not in use here, but it is being used about, so you should know what is happening, new thing. Practically, maybe too far for us, maybe too far. Maybe 5 years, 10 years before we started doing first stent. But still, you should know what is happening, what is MIGS. MIGS is a new interventional surgery like early cataract refractive surgery, as I told you. People have got a mild cataract, they have got a astigmatism, they have got a glasses, they have got a myopia. They want, doctor, I'm fed up of glasses. Oh, early cataract is there. You give him advantage, yes. Treat the cataract, treat astigmatism, treat myopia, treat hypermetropia, treat presbyopia. Good quality of life to the patient. So similarly, new interventional study like early refractive surgery, and what you do that you usually combine it with the cataract surgery. Usually, because that's time 2 surgeries, you can combine it rather than doing the patient also. And more IOP control required than medical and laser surgery. It is indicated when medical and laser are really not, not working, then in this case, more IOP control is required. Not effective in patients who need aggressive. Suppose patient is advanced glaucoma, it may not work yet. 0.8 cupping, 0.7, you need to go for trabeculectomy or advanced surgery for that purpose. Aggressive surgical intervention means trabeculectomy or valve implants. This is what we need. If not effective in patients, this is what? This is ab interno micro-incisional approach. We are not cutting the eyeball, making an incision from outside to inside the eye, like little. This is an ab interno. Means we are going inside the eye, then we are making the incisions. Ab interno. One is ab interno, other is ab externo. When we are making incision from outside, ab externo. Although we are entering from outside, but we are not making an incision. You see, that's why we are calling it ab interno. And micro-incisional approach. It has got a, remember, at this stage, it has got a moderate efficacy, not a very high pressure. But the important, it is minimally atraumatic. It's got a very, like trabeculectomy, you are making flaps, bleeding, fibrosis, and so many things going on. It is minimally atraumatic. And it has grown tremendously last decade, particularly in USA. UK people are also doing, but USA people they are quite aggressive in this mix. And now it is major part of the glaucoma surgical paradigm. So now this is the man, Iqbal Iki Ahmed. He is the man who is leading the mix in whole world. Imran Masood is also his trainee. He got this fellow is the person in Canada. He is in Toronto. He's the top man in glaucoma nowadays, mix and everything. He is fantastic man, and he's doing. Why I give you two pictures with this surgeon? Because he's famous for his long hair. That's why I gave you this picture. This is the only ophthalmologist I have seen all over the world are pictures. He's famous for his long hairs. He always, sometimes, most of the time, he puts ponytail. Coming to, most of the time he puts ponytail. Even in conferences, he puts the ponytail. Like, so this is the man. Because you should know the famous people who are famous in their field. You should know them. Those people. Who is best in cataract? Who is best in phaco? Who is best in oculoplastics? Who is best in VR? You should know that. And belongs to where? What is he doing? This is very important. That person should be known. Okay, now mixed strategies. What we are doing in minimal glaucoma, the strategies, there are three types of strategies. We are dealing with the angle. The philosophy is that you treat where there is problem. See? You have got a Schlimm's canal mix, suprachoroid mix, and subconjunctival mix. Now look at this angle here. This is iris ciliary body, iris flow here, and this is the angle here. Okay? And the flow is also from suprachoroidal space. Here it's flowing in the out. The problem in open angle glaucoma, we are talking about open angle glaucoma, not angle closure. That's also in the angle. Here in the trabecular meshwork. So the philosophy is treat where there is problem. Treat the problem where there is obstruction. This is the philosophy. Be more physiological. Where there is pathology, treat it physiological way. Okay. So now Schlimm analysis. Now this is the angle, just to show you this. See the angle here, iris. Now you know three types of the trabecular meshwork: the uveal, scleral, and the juxtacanalicular. Okay, so these are the large pores, medium-sized pores, small pores. Where is the resistance? Where is the resistance? Juxtacanalicular. Okay. You have got normal resistance. And that resistance is here in this green zone, which is juxta to the canal. Why name is juxtacanalicular? Because this is the canal of Schlimm. It is next to it. And smaller pores. Here is the resistance to the aqueous. Aqueous flow is slowed down. And this resistance keeps your intraocular pressure. Normal intraocular pressure it gives you. But if the resistance is increased, intraocular pressure will become high. So this is the problem is here. So you treat this area. This is the philosophy in mix. No, is that right? Yeah. You might be having different ideas, but this is how it is. Yeah. So this is, look at the angle here, very good, nice picture. This is how the pores of the trabecular meshwork here. This is how the aqueous through pores, and this is the canal of Schlemm. And from canal of Schlemm collecting channels, the fluid goes out. Very beautiful picture. That will give you, visualize you how the aqueous drains out from here and then here comes out. So what you do, you drain here. So canal of Schlemm, so what you do, bypass this obstruction with some stent. It's same like in angioplasty, your coronary arteries, there is a block there, put a stent there, enlarge it, fluid goes out. Similarly, what you do, you put a stent here and bypass this obstruction so that the fluid can pass through this into collecting channels. Don't disturb other things. Don't disturb other things. No disturbance of other anatomy. Physiological process. Whatever normal physiological process is, bypass it, pass through it, and let it go through normal. Normally, what we are doing in trabeculectomy, we are making the fluid to come into subconjunctival space, which is non-physiological, which is not physiological, non-physiological. Mix is what? Drain the fluid, your natural process, natural path. You just put the here and this area, bypass it, put a stent here, fluid pass here, it will go on its way out. So this is micro stent hydrant. This is slightly advanced. I think you have got a hydrant. Yeah, you are. Yeah, early stage was the eye stent, which you are probably putting. Yes. But this has got the long and the distances. So this is the what at the angle you put this goes into the canal of Schlemm, and the fluid passes through this, and then it drains out from here. Video. This is also video of Iqbal Ahmed. So this is, see, this is simple procedure. Although it's a very, you put the needle in it, you go gonioscope, you go into the angle, make a nick. This is what, it's a sharp needle there. It's going to make a nick here. Now you have punctured trabecular meshwork and entering into the canal of Schlemm. Then what is going to do, similarly in that needle, there is an implant. So the implant, push it implant from the back into the canal of Schlemm. See the implant is going. Oh, sorry. Can you carry on? This is puncturing of the trabecular meshwork. And then entering into the canal of Schlemm, and then injecting. Inside there is a stent. See, the stent is going. So the stent is going into it. Because in the canal of Schlemm, you can't see it in it. it extends about this area here. And that's it. That's, you can see the length of the stand up to here to here. Long stand, and to here and dilates that thing. Okay, thank you. And then this is the opening of this thing. From here, the fluid will be going, and it is going to drain through the normal process, natural processing. Back to it. Over you go. Back. So this is the stand. It goes in, the fluid comes out, and this stays here like this. And that's it. It goes through the whole process of from here, the fluid is going back. Okay. Now, similarly, there is another device which is you use the suprachoroidal mix. You put the device here in the suprachoroidal space, the fluid will be going into the through the suprachoroidal mix and through this area, rather than the conventional. This is our angle, but it is going through this. So this is another, the Cypress device. And subconjunctival, this is slightly less physiological, in which what happens that you put the fluid, the device from the anterior chamber into the subconjunctival space. You are not cutting the conjunctiva, you are not cutting from the conjunctiva, but from the anterior chamber, you are cutting the angle here with the micro forceps space, and then injecting this tube here, cutting it with the knife. These instruments are small MST instruments, which she was describing, microsurgical technology. They are called as MST. Now these instruments, they are these microsurgery they are used. They are specialized instruments. They go with small, very small incisions, as she was using MST for the goniosinoculosis. So this is also, you make an incision here. In this, similarly, inside it, there is a tube. Tube is going through it, and you leave the tube, take this out, and from this tube, it is going to subconjunctival space. This is not going into the normal physiological process, subconjunctival, but your conjunctiva is intact. So chances of fibrosis are minimal. The fluid is collecting here. This is your fluid here, tube here. The fluid is subconjunctival. So blood will be formed, but there will not be any. Yes. So just to conclude now, that glaucoma surgical space has grown, means now people are thinking a lot more about the surgery of glaucoma, how to make it better. Interventional studies and approaches are evolving. They are evolving with the time. Well-designed randomized trials are being done, and they are necessary to find out the efficacy and the problems related to it. It minimizes, so what they say, minimize challenge of medication adherence by SR medication, SLT, and mix. Means the challenge of medication compliance, minimize it. The problem is now that people find that the medical therapy, longer the medical therapy, more chances of problems, surgery results will not be good, patients will be losing the sight as well. So minimize that so that the therapy, patient's IOP control should be in your hands rather than patient's own hands. It should be your hands. So minimize challenge of medical addition by SR medication, and obviously surgical skill is a big challenge which needs to be learned. No, you like this?
Yes.
Like this. So this is the gentleman, Imran Masood, top man in UK with me. Yeah. Thanks God you added one more. First one, and then you made it two. Yes. So you are two mentors, the earlier mentor and the later on mentors. So nice gentleman. Dr. Masood, I met him. It was my really proud to see him there when I came to BMAC, and we met there and we had a lovely time. So thank you very much. This is the talk about, just to give you an idea, just to give you a thought-provoking thing. Think in a larger terms now, rather than making a limited approach towards glaucoma, where the world is going and what we should think about it, considering our own. I'm not saying we should abandon. Currently, we have choice. We don't have a choice other than trabeculectomy, goniosynovitis, which you learned last 2 days. No. Currently, we have to master these things. We cannot ignore it. But simultaneously, at the time, we should know where the world is going. What is the trend nowadays? Okay. Similarly, in every specialty, in VR, in oculoplastics, phaco, diabetic retinopathy, AMD, where the world is going, what limitations we have got, what we are doing, because we cannot be unlimited. We have got limitations. Yeah, but simultaneously, we don't know what the world is doing. So this is what actually this is what I became a little bit educated in last 1 month that I went out. I became a little bit educated, whatever I have shared with you. So thank you very much. Anybody have a question? Yes.
I got the message from her that gonioscopy,
Yes.
3 times. She also mentioned in her slide.
Yes.
And after that, after you are finishing, now I got the message and take home that it is the mix.
Yeah, but we are far away from it. You solo come good. The limits are in your time.
Thank you, sir.
I want to ask, yes, Rashid was there, just left, I think 5 minutes ago. He was apologizing because he has to leave. If there anyone from BPOS, if anyone, Ejaz Saab or any other person? Yes, Ejaz Saab is there. Rashid Saab is also there. We would like to have their comments. Definitely. Rashid Saab and then Rashid Saab, yes. So please, your comments. Rashid Saab.
Yes. So about the conference, or is there a question I missed it?
Somebody has asked a question as well. And in the last, Dr. Sadia, yes. Please unmute yourself, and please, if you want to ask a comment or ask a question or comment, please.
Assalamu alaikum, everyone. I hope all of you can hear me. I must congratulate Dr. Khalid for excellent seminar. So I'm so glad such academic activities are going on in Pakistan. All burning issues highlighted in the seminar, and especially angle surgeries, bloodless MIG procedure. This is the new avenue you all must be focusing on. So I'm very happy that you have highlighted it, and people are recognizing this thing. And Dr. I should say as well, we must be thankful to BPOS for bringing a change in the management of Pakistan regarding glaucoma. And I must second his trabeculectomy, which the survey has conducted. And I must add to this that the strategies that we have changed under his guidance, has made improvement in the results of trabeculectomy we are doing in our population. I'm very much more comfortable now in advising trabeculectomy to my patient. The outcome is predictable now, and the variables are being controlled. So as we introduce MIGS and other procedures as well, we must master trabeculectomy as well, because this will always be in our armamentarium. So thank you again for allowing us to be part of this academic activity that was there.
Thank you for the valuable comments and the things. I would like to ask Dr. Rashid. Now, please, if you have some comments, if anyone has questions, or we can directly go to comments.
Thank you very much, Mohsen sir and Professor Khalid Talpur, and thank you for kind remarks, Sadia. I'm very grateful for this opportunity, and I'm humbled by this invitation. It was an excellent seminar. I unfortunately did not attend the first 2 days. I'm not sure whether they were available virtually, but the content was very good, and I was constantly in touch with Dr. Noor and Umair. And we were discussing the topics and the clinical pearls which were discussed, and it was an amazing content. So I'm very, very happy that we're all moving in the right direction, and I'm hoping that in the future, under the auspices of Professor Khalid Talpur and other senior colleagues, Pakistan will also be engaging into world-class research. Thank you very much.
Thank you, sir, for your valuable comments. I think Ijaz Sahab is also with us. So would you like to comment?
I must say there is much to admire in conducting this 3-day seminar with hands-on training, live surgery, and this great academic session today. So the greatest triumph is not what has been done, but how it has been done. It is through camaraderie, communication, and collaboration. And I believe with the data tools available for audit purposes, we'll be able to generate a lot of papers. Even if you just consider the Institute of Ophthalmic and Visual Sciences, so much of data is available. We can guide you. We have the team, youngsters, seniors who can help writing the papers, getting it published, and to bring the name of your institution at international level. So congratulations to everybody. Despite limited resources, you're doing a wonderful job, and look forward to have more of such webinars, seminars, and conferences. And not only in glaucoma, which is reasonably well established now, to other fields like cornea, and we can do maybe pediatrics and things like that. So look forward to cooperation and coordination. Thank you very much.
Now, let's move towards conclusion of the seminar. I would like to ask Professor Khalid Talpur to please come and have a conclusive remarks about the whole 3-day program. Thank you.
Thank you, Master. First of all, it has been a great occasion, and it is our proud privilege that we have this BPOS have been collaborating with us, and it has been a joint venture between them and with us. This is, I think, in our history, in Hyderabad's history, this is first time. I don't know about the other places, but obviously this is a good example for us and good beginning. And with this, we are going to further enhance our collaboration in research, in human resource training, and webinars and other things in which we can increase our capacity and efficiency to improve our work. So thank you very much, BPOS, for collaborating and sparing time for joining this occasion and helping us in organizing this event. The Dr. Mohsen is obviously is a person who has of extraordinary qualities. This man has done a wonderful job collecting us here and having this wonderful seminar here. All of you have been attending this and have been learning from this, particularly my residents who are here, and they must have learned tremendously in this thing. And they have a lot of insight about the glaucoma overall and other aspect of the ophthalmic related problems. Other than that, all the faculty members of the SIOVS and Dr. Jokyo, and I must not forget the IT department, they have done a wonderful job in organizing this event. Like, it's live on the Facebook, and so this is a very good job. In the end, I must mention the sponsors, our sponsors, Allergan. They have done a wonderful job by sponsoring this event, and they have been always doing all these events coming up forward and sponsoring these events. So thank you, Allergan, for coming here and helping out. In the end, our not the last but not the least, Dr. Noor. She has she has been our candidate here, our trainee here. She started, I still remember when she first started ophthalmology, and first how much she was apprehensive. First few days, she was so apprehensive. She thought that every day she used to come to me and tell me that where I am and how I'm going to do this training in ophthalmology and what, she was a lot of many things coming in her mind about the ophthalmology, that whether she will be successful or not. And look at here now, after how many years? 10 years, is it? 10 years down the line, where she is now. So this is, we are proud of her. It's our, that our trainee is now in such a good position and wonderful place, where she is not only doing a lot for herself and building her career, but she is so much helpful to us. We in the future also, expecting a lot from her, from every respect, because this is her place. She started here. She was, this is her alma mater. So I think she will definitely take care about SIOVS and the people here as far as the development and the education and training is concerned. So thank you very much, all in all, everybody who has joined it. If I'm not taking the names, so please forgive me. So thank you very much. And I hope that in the future, we will be arranging more and more programs like that. And that will be beneficial to all our ophthalmic community, as well as and ultimately we are going to help our patients to, save their vision and sight. So thank you very much, everybody.
Thank you so much, sir. And it's a tradition that we welcome our guests and we decorate our guests with the beautiful colors of sun. So I would request Dr. Noor to please come to the stage, and I would request IT team
request Professor Prasad to please decorate our guest with the addition of the same measure. It's a sheet for light surgery workshop.
Yes. Very lovely memory.
Some gifts are also brought to you by the Elegant Pharma from Dr. Sir. Representative, you would like to present some.
Thank you so much. Thank you.
We would like to declare our sponsor as well for the sponsorship. Thank you so much.
Thank you.
So I would like to welcome Mr. Fahid to the stage. Okay. So from the Pharma, sir, please decorate our sponsors. Thank you so much. Thank you.
Well, guests have been regulated, but one person not regulated is not justified. And that is the man, Dr. Mosi. He has played 3 one-day matches, and all 3 of them he is man of the match. So you have got to see what I got that. Take correct. Come please. Okay. Good. Really appreciate it. For all of you. Yeah, I know.
Very honest.
That concludes.
This concludes the ceremony. Last but not the least, because of the COVID situation, we have arranged some boxes for you to take home with you to disperse. And any comments if you want to give other people? So then,
Hope to see you again very soon.
We are very thankful to the guest.